Navneet Anand Kumar sir has joined.
Not yet, sir.
Okay. Give him a call. I have called him around 10 minutes back. He said he
sir.
will. Are we live now?
Yes, sir. We have just started.
Okay. K. Ravishankar. K. Ravishankar. I will do that. I've got all details.
Good evening, Madhikar sir.
Hi, Arvind.
Hello, sir.
Not लग रहा है।
अंदर लीजिए हम।
ये किसने लिए माला पंजाबी?
पता नहीं, मैंने नहीं लिया।
ऐसे लोगों तो मैं कोर्स नहीं बना सकता।
यार किसका है?
मल्लिकार्जुन रेड्डी है इसमें होस्ट।
Shit.
Hi, Rishi.
Good evening, sir.
Yeah.
Nice to see you.
Green launch में
How
बैठे
are
हो?
you?
Green launch में बैठे हो बैकग्राउंड पे?
हाँ बिल्कुल. Green launch.
Hi, किशोर. क्या सगा जी की हाल है?
आप कैसे हो?
बस चाय तो पी रहा हूँ यार, दारू तो नहीं है अभी, तो काफी टाइम है.
You are managing back-to-back webinars, huh?
नहीं, अरे यार मैं अभी तो देखना बंद कर दिया. मेरा वेबिनार ही देखता हूँ और कोई वेबिनार नहीं देखता हूँ.
I'm dealing.
The only thing what I am surprised going to be is लोगों से ज्यादा वेबिनार होने लग गए. Webinars than the number of people available. So I don't
Absolutely.
know. तू घर पे बैठ गया ना इतनी जल्दी? तो राजीव लॉकडाउन करा रहे हो कि नहीं करा रहे हो?
Most likely they are waiting. They are randomly testing 50,000 people.
तो सब जगह पे हो रहा है, हमारा पास भी हो रही है.
So they are calculating how many will come positive depending upon the
20% on day one in Hyderabad. 17% of the testing samples were positive. 17%.
That's quite a number.
Significant number.
Yes.
We see now, we are seeing started now, and within short period of time, we started seeing false negatives becoming positive after a week.
In a way, that also means that most of the people are actually getting immune.
Yeah, of course.
Lockdown may not be required.
May not be helpful. Let it be.
Yes.
So many
Let it
asymptomatic
be.
fellows are positive. Us, I don't know. We just sent him off and say that to come back after 2 weeks. We'll do the surgery.
Yes.
अजय बाबू, गोल्फ का टाइम नहीं हुआ?
अभी सुबह में गोल्फ होता है बॉस.
ये भी नहीं मालूम मुझे, क्या करूं यार.
लॉकडाउन के बाद गोल्फ चालू हो गया तुरंत.
ये भी नहीं मालूम है मेरे भाई, यही प्रॉब्लम है.
गुड इवनिंग. हेलो.
Good evening, Anish sir. Good evening.
Good evening, sir.
हेलो. हाय.
Good evening, Ajay sir.
तो डॉक्टर मल्लिकार्जुन, आप कह रहे थे ना कि आप 3 वीक बाद बुला लेंगे.
हाँ जी.
वो अगर मान लो उस 3 वीक के बाद जब आने के पहले जब एक्सपोज होगा तब
तो फिर करेंगे ना उसके पहले. उसको थोड़ी करेंगे.
मेरा तो वो तो देखो वो वाला विंडो पीरियड तो वो तो भाई कोई बचा नहीं सकता. 5% है. दो कोविड नेगेटिव करके भी विद इन ए डिफरेंस ऑफ 5 days. दैट इज व्हाट वी आर डूइंग. ठीक है, क्योंकि 5th डे पे जनरली सिम्टम्स वगैरह आने
लग जाते हैं.
होता है. हाँ, ये होता है. या चांसेस आर दैट यू विल गेट ए वायरल काउंट. तो उसके बाद भी 90-95% है. फिर भी 5% से 10 तो वो है. वो आप कैसे भी नहीं कर सकते हो, क्योंकि उसके साथ अटेंडेंट भी रहते हैं। वो तो आप भगवान के, हम लोग वैसे भी नियर हैं भगवान के अभी मतलब
इतना
तो
जल्दी नहीं
वो तो
यार,
थोड़ा
इतना
छोड़ना
जल्दी
पड़ेगा।
यार, अभी बहुत टाइम है, अभी बहुत टाइम है। अजय, मॉर्निंग के टाइम में सिंगल बॉल की गोल्फ होता है, इवनिंग टाइम में 2 बॉल की होता
है।
है। मॉर्निंग में 1 बॉल की होता है, सिंगल इवनिंग में 2 बॉल की।
राजीव कैसे हैं? और राजीव, हाउ आर यू?
राजीव तो सुन रहा है।
राजीव का म्यूट अनम्यूट करना पड़ेगा ना।
नहीं, is unmuted.
अनिश, दूध पी रहे?
दूध नहीं है आज।
यार तेरे को देखो तो अभी तू बोलता है कि नजदीक आ गया। हाँ, दूध पी रहा है अभी।
ये लस्सी अभी अभी एक मल्टीपल वेसल का ना ट्रांसप्लांट करके अभी भाग के आ रहा हूँ। उदय इज डूइंग यूरेटर। हाँ, तो मैं अभी एकदम आई विल कंटिन्यू टू सिप समथिंग और अदर टिल इट इज द सनसेट। और आप क्या पी रहे हैं भाई?
यार अभी मैंने वॉच का ऑलरेडी आई वॉच माई सेल्फ सेइंग दैट आई एम ड्रिंकिंग ओनली टी ओनली, दैट्स ऑल।
अभी तो कॉफी का ही टाइम है।
टिल व्हाट टाइम? अप टू 6:30,
7
4:45?
7 होम। अभी तो
गुड इवनिंग ऑल।
रहना बेकार है हॉस्पिटल में।
गुड इवनिंग मलिक
गुड
बॉस।
इवनिंग, गुड इवनिंग भैया। आ गए?
क्या हाल चाल है?
ग्रीटिंग्स फ्रॉम नेलोर।
नहीं सर, अभी हैदराबाद से सर, आज
अभी हैदराबाद
घर से।
हेलो हेलो, नमस्ते।
नमस्ते सर।
Good evening, sir.
गुड इवनिंग। यार ये 5 बजे की जगह इसको 6 बजे करो यार, अस्पताल से वापस आने में टाइम हो जाता है ना।
हम लोग तो अस्पताल में ही करके जाते हैं, एक साथ ही घर जाते हैं।
आधा वेबिनार तो मैं सुना कार से हो रही है आपकी।
अभी अब
क्या फर्क पड़ता है सर? आपका तो आधा तो वेबिनार कार में चल रही है आपकी, मेरे ख्याल में। थोड़ा बड़ा सा स्क्रीन लगा दीजिए कार में, काम खत्म हो जाएगा। बैकग्राउंड बदलता जाएगा, बैकग्राउंड बदलता रहता है ना हर वक्त। फिर
ये क्या हुआ? ये क्या हुआ? ये क्या आ रहा है कुछ?
ओपनिंग बैट्समैन कहाँ है? सोपन कहाँ है?
क्या आनंद कुमार सर क्या दिख रहा है?
इसमें एक आ रहा है किसी का, somebody is trying to enter with अजीब नंबर के साथ।
अरविंद की परमिशन के बगैर कोई एंटर नहीं कर सकता।
नहीं, that is actually Navneet is going to give the permission.
नहीं, तो किसी के नाम से नहीं आ रहा है, अजीब 6, 7, 8 CD4 ऐसे
Two people have entered the waiting room for this meeting. People are in waiting first and then they can join.
Waiting room means every time he will be logging in, so he is checking it, and before that, after that, he is going to do that.
Anand Kumar sir, Rajiv sir has probably exited the meeting. So
no, he has just talked to me.
He was there right now. He's not seen. It's 5 o'clock. I'll just call him, sir.
No, he just talked to me. He was there.
He was there with us. He was there.
He was there. He just talked to me.
Hi Oswal, Ajay, कैसे हो रहे हैं?
बस बढ़िया।
गुड इवनिंग सर।
ठीक ठाक।
अच्छा, अजय ओसवाल भी है।
गुड इवनिंग सर।
क्या हाल है?
फाइन सर।
Okay, sir. Okay, sir.
टक्कू आ गया? टक्कू has come.
Hello.
How
are you, sir?
तेरा नाम को पीडियाट्रिक बना के टक्कू बुला रहा हूँ यार, क्या करूँ?
How are you?
चल रहा है गाड़ी?
All well?
Good.
Good evening, sir. Anand Kumar, sir.
Good evening. Namaste.
Arvind, good evening.
Mallikarjun,
Good evening, Anil.
Huh?
Hello.
Mallikarjun, your video is quite interrupted and shaky.
Mine? Cannot be.
Yes.
Very clear.
We are
Very clear to me.
It is clear.
No, ठीक है मेरा तो
All
50
videos are
MB
clear here.
हाँ
Rajiv sir, should we start, sir? Rajiv sir?
50 MB
Yeah, Anand Kumar sir has joined. Navneet?
Yeah, he is there, sir.
Yes,
Okay,
sir.
sir.
Joined.
So, respected President, Urological Society of India, Professor Anand Kumar, President-elect Dr. C. Mallikarjun, the esteemed faculties for this webinar, viewers from Urological Society of India as well as from fellow members from the SAARC countries. Welcome to you all for today's webinar on complications in urology. But at the outset, I have to say some very sad news, because today there was a sudden demise of our beloved member, Professor K. Ravishankar, who was one of the first batch of MCH urology from Madras University. He was born on 1st of March 1934. He was one of the active members of the Association of Southern Urologists. He has also delivered the prestigious Pinnamanani Oration of Urological Society of India at the Kanyakumari UCCon. So on behalf of the Council of USI, I convey our heartfelt condolences to the bereaved family and pray for the eternal peace of his soul. So I would like all the members to have 1 minute silence as a mark of respect to the departed soul. Thank you, everyone. Now, this is another in the webinar series of Urological Society of India and the Indian School of Urology. And today, the session will be moderated by Dr. Arvind Ganfule. And we had lined up an academic feast, in fact, and various experts will be speaking on various complications in the field of urological practice. And I once again welcome you all. With this, I request the President of Urological Society of India, Professor Anand Kumar, to address everyone. Over to you, sir.
My dear friends, fellow delegates, all the participants and the faculty members. This is a very interesting webinar on complication in urology. You know, we all do a lot of surgery and we all do complications. Some may do less, some may do more. But if somebody is saying he's not doing any complication, then there is only two possibilities. Either he's not operating or he is lying. And then again, by these webinars are studying the complication is very important. You know, there used to be book on complications, because there is a two-way you can learn. Either you commit a complication, suffer, learn, or like a smart guy, watch others, what they have done, how they have committed a mistake, and how they have taken care of that situation. So by watching others' complication and they're taking care of it, you learn a lot. So if you encounter similar problem in future, you will be a smarter and a better guy to handle that situation. And this webinar is covering almost all aspects in urology, and it is finally, they'll be showing a complication and then it will be asking the opinion how it can be handled. It is a very useful one, and with that I'm very happy that everybody will be enriched by it and improve his skill and decrease his complication rate. And at the same time, you know that this COVID pandemic is going up, and there is still surge is not come, even though government is denying community transmission is already there. And we are seeing a lot of patients in Delhi. Hospitals are getting full, more and more beds are taken over, more and more hotels are taken care of. So I'm not trying to scare you, but I want you that be careful, look after yourself, look after your loved one and family. Don't put your guard down, so that you are healthy and you are ready to look after your patients. So with that, I inaugurate and I pray for the good health of all of you and all the members of the Urology Society of India. With that, I inaugurate this conference and welcome you all. Thank you.
Thank you, sir, for your enlightening words. With this, I hand over the proceedings to Dr. Arvind Ganfle, who is moderating this webinar on complications in urology. Over to you, Arvind.
Thank you very much, sir. At the outset, I must thank the USI Council in general and Dr. Rajiv TP and Dr. Anand Kumar in particular for considering me worth this assignment. I hope that I will meet the expectations. So we will be having this webinar, which has been divided into 7 subspecialties, and then we'll be dedicating half an hour for each of them with an expert comment after each one. I make a small presentation. This is a video grab which I had taken from an CNN Pepsi truck crash, which is available on YouTube. You can see that the Pepsi truck has jumped the dual carriageway and has jumped on the opposite side of the carriageway. So for an, yes, sir.
We can't see that.
We can't see that. Slideshow.
Arvind, go to slideshow. Arvind, go to slideshow.
Yes, yes, I'm doing it. Can you see it, sir?
So we can see your slide, but the video we can't see. Next one. Yeah.
Can you see the video?
Yes.
Now we can. Yes. So I'll go back to the video. This is a YouTube video that was captured from the CNN archives. You can see that a Pepsi truck has turned on the opposite side of the carriageway, and for an cursory onlooker, the Pepsi truck driver was the person who was responsible for the accident. But if you go into the details, you see that actually this SUV driver was responsible for the whole thing, and he had actually jumped the lane, and he was the culprit, and he was the guilty person who actually caused the Pepsi truck to go on the opposite side. So why do I show this particular thing here? Because I want to draw the fact to the importance of documentation. If it was not this device, we would not have fixed the culprit. The same thing holds true in an operating room as well. As we go on recording our open surgeries or maybe even endourological surgeries, we are in a position to fix the guilty and learn from our own mistakes. So the point is, the complications might happen with you as well. We should not forget this famous statement from Gordon Kelly, wherein he says that there is no danger that the Titanic will sink. The boat is unsinkable and nothing but inconvenience will be suffered by the passengers. Words that have gone down in the history for all the wrong reasons. It can never be so that you should never come in your mind that it cannot be me. Remember, you may be next in the line at the receiving end. So the holy grail of management of any complications are that you should analyze, you should introspect, you should ask for help, and always share your complications. And finally, document them. So the bottom line is that a disaster and a complication may be around the corner. At one needs to know is how to manage them. And the only solution is be prepared for it. And in the same endeavor, I must thank this galaxy of speakers who are there and who are experts in their old field. They always say that you learn from complications from others, and I'm sure that this will be an academic enriching experience for all of them in the next 3 hours. Having said this, I stop my slide share and invite the first faculty to do his presentation, and it is Dr. Ankit Fuskele, who will be presenting how he managed a case of accidental pneumoretroperitoneum. Ankit, over to you.
sir, am I visible?
Yes, you go to your first slide. You are audible very well.
Okay, sir. So thank you, sir. Thank you, USI and Arvind, sir, for giving me this opportunity. This is a case of 19-year male who's a very thin-built boy, had a left side non-functioning kidney with a split function of 9%. And there was a chronic obstruction because of the stone, which lead to the non-functioning of the kidney. And because patient was symptomatic on that particular side, so we planned him for left-sided laparoscopic nephrectomy. And for laparoscopic nephrectomy, what I practice here, that we keep the position into the left lateral position, and I use various needle for creation of the pneumoperitoneum. So after creation of pneumoperitoneum, I first put a 5 mm trocar for visualization of the peritoneum. So I will go with my first video here. So what actually happened, I'm putting this 5 mm camera here. Nothing was visible. Almost everything was like a blood. So I was not having any clue actually where I am. Now again, I went inside, I cleaned my camera, and I'm able to see some film C structure and this particular sort of some injury there. And you can see in the picture there, these are the trocars. So when again I proceed inside, I was able to visualize something. I was able to inspect there, and then I could see this ballooning of the air inside. And further going up, I could identify the colon. So then I was sure that yes, I'm not outside the peritoneum, but I am inside the peritoneum. So I inserted my next 10 mm port. This. So, yes, so after insertion of 10 mm port, again, you can see this is the Barry's needle tip actually. This is lying inside the retroperitoneum, and I suspected that probably there may be a colon injury, or I was not aware where actually the needle has gone. So this is first thing which happened. And so, sir, before going to this thing, whether you want to discuss on this thing? Before going how
Ankit,
it happened.
Ankit, actually, you go ahead. We'll take all the three presentations, and then Mallikarjun sir will give his opinion on that.
Sure, sir. So, I'm going to the next video, how I managed it actually, sir. So by this time, actually, the situation was under control because this one. Because I was able to insert the 10 mm camera over there, and the moment I removed the CO2 from the varus needle, there was loss of the retroperitoneal insufflation, and all the retroperitoneum desufflation happened. And now you can very well see that colon is lying over there. This is my 5 mm port, and this is a needle entry point you can see at this point of time. So I recognize the entry point here. And I was suspecting that maybe it is traversing through either through the colon or through the mesentery. So I tried to trace the tip. Actually, before removing it, I thought I should find out the total course of this needle. And I was able to identify some, you can see on this colon also, a point, apparently there is a point of injury. And this was the point of entry in the mesentery. So there was no active bleeding, and it was going through the mesentery. So now I started mobilizing the colon. I kept the needle there itself only to explore the course. And now I can identify this thing. You can see that needle tip is inserted into the psoas muscle. I was luckily escaped, because if I could have gone a little medially, probably there may be a chance of injury. So this way, then I slowly just removed the needle, and it was safely removed. So this way the needle was removed. I inspected everything. There was no major injury there. And then I completed the left side laparoscopic nephrectomy. It was done well, and patient recovered without any further complication. So when I reviewed all my videos and all the episode what happened to me. So I could reach to this point. Why did it happen? So first thing was point of needle insertion. So in practice, I used to insert a needle. This you can see. This is the point of needle insertion between the umbilicus and the anterior superior iliac spine. This is a midway point, and this patient was thin and like a child. And probably that may be one reason that I reached little lateral. That may be one cause. Though I did all this injection, aspiration, and hanging drop technique to ascertain that my needle tip is inside the peritoneum. But one thing which I remember that I took at least 3 attempts actually. When I inserted the needle, I was not able to get either the injection was not proper, and if it was injecting, the aspiration was not there. So I was not satisfied in first and second attempt. So I have to take 3 attempts. And when I started insufflation, so what actually happened there, the distension which was apparent to me was not sufficient, though the pressure was normal. So I was able to achieve the pressures, but distension was not adequate. So I asked my anesthetist to give muscle relaxation. I was thinking that probably the patient is out, and because of the spinning over the muscle, I'm getting the high pressures. So maybe at this point, these were the warning things I was supposed to see here. That probably I was not in the peritoneal and distension was not sufficient. So these are the things, and this is one article I want to bring to everyone here. This is very good slide. Complication related to needle insertion is related to attempts actually. So when you see when the number of attempt of inserting a varus needle is 1 attempt, you go, there are chances of around 0.8 to 16%. You may create complication. But when this number of attempts increases, like if you take 2 attempts, the chances of complication may rise to 16 to 37%. And when the number of attempts increases to 3 attempts, probably it may reach to more than 50%. And if someone is taking more than 3 attempts, then there are chances of causing some or other complication, maybe reaching to 80 to 90 or 100%. So this was a lesson for me, because I was taking attempts at the same point of insertion, and maybe that is why I caused the complication. Probably when I was not able to do a proper insufflation from one insertion point, I should have either changed the point of insertion, or maybe I should have taken an open technique for this patient. Thank you, sir. So I'm ending my presentation, sir.
Arvind, you have to unmute.
Hello.
Yeah.
Yes, wonderful, Ankit. I think we'll take all the questions after we finish 3 presentations together. We'll go straight away to the next presentation by Dr. Swapan Sood, and he's going to let us know how we managed and post RARP or psychourethral anastomosis disruption. Over to you, Dr. Swapan Sood.
Hello, good afternoon, everybody. And first of all, I want to thank USI and Arvind for allowing me to present on this forum. I hope you all can see me.
Yes, very nice.
Can you see the slides also?
Yes.
Okay, great. So my talk today is on anastomotic dehiscence after RARP. And for this, I'll just quickly go through what happened, and then why it happened, and then what was the literature regarding. This was just a ordinary walk-in patient, a health inspector from the HP government, non-smoker, non-alcoholic, had LUTS for several months and he was on medical management for all this time. He was one of all the common patients who enter our OPD every other day when you are doing your OPD. He had acute retention of urine, and on a day, 39 days before surgery, he presented to his local practitioner with a PSA of 16.5 and an acute retention of urine. His ultrasound showed 29 grams prostate. There was no other contributory comments were there. There was no information on the rectal examination. He therefore underwent a TURP in a peripheral center, which was a small prostate as per the operation notes, and just wanted route evacuation. Small amount of tissue was resected, and it was then histopathologically reported for adenocarcinoma of the prostate, and he was referred to our center. So about 25 days after he had undergone his TURP, we conducted a multiparametric MRI, and from the MRI we were able to make up an equivocal kind of a MRI was there, and there was no capsular invasion, no lymphadenopathy, which were the two main important factors which we were looking for. And his bone scan was negative, and he was given an injection Pamrolin 11.25 milligram. This is about 25 days after the thing. The patient, he was taken up for a robot-assisted radical prostatectomy and a PLND. It was a uneventful procedure. Patient drain was removed after 24 hours, and the patient went home the day after the surgery was conducted uneventfully. You can see that this was a urethrovesical anastomosis in that patient. I was able to get a good look at the bladder neck, and I had no inkling what was going to happen next with this patient. 12 days after his RARP, he came with complaints of pericatheter leakage. We did an ultrasound, and it showed a mild free fluid in the pelvis. Well, we didn't pay much attention, and except there was a small warning sign, our radiologist was able to see the prostate even after we had done a radical prostatectomy, as you can see in the screen right over there. Let me just turn on the laser pointer. So he was able to see the prostate, and that should have given us a inkling, but we thought that it was more related to his inexperience rather than, or his hurry rather than any other cause was there. So we sent him home on bilateral accents. He came back another 9 days later with the same complaint. Typically, we remove the catheter somewhere about 3 to 4 weeks after surgery. And he came back. This time there was no urine coming inside the urine in the bag. So we did a cystogram just to check on the urethrovesical anastomosis and any leakage that might be there. And we found this was the cystogram. The Foley's catheter, you can see nicely, it was lying outside somewhere of the bladder. This was followed by a CT scan to confirm what has gone on. We did a CT pelvis, and you can see the catheter lying posterior to the bladder. Again, you can see the catheter lying posterior to the bladder, and this is the bladder, and the posterior wall is also seen with the this thing. So what had happened? We were not sure. There was probably a urethrovesical disruption, whether it was partial, total, and we had either we could go in for cystoscopy or we could go in for exploration. It was a robotic radical prostatectomy, such a premier operation that the patient expects that one is paying that kind of money and that kind of technology, then there should not be any kind of a complication. And lo and behold, we had a urethrovesical disruption. I had never seen it before. I hadn't had an opportunity to hear of it before. So I did a cystoscopy. Unfortunately, I lost the video, but when I did the flexible cystoscopy, I could see that there was only a small connecting strip, about 1.5 millimeters anteriorly. The rest of the bladder had dissociated or disrupted from the urethra and was lying totally separate, and there was a large cavity below the bladder from where the catheter was there. And this was the cystoscopic findings. This was 21 days after surgery, and what had happened was that patient had a urethrovesical disruption. So coming to why I think the disruption happened, our first clue was probably the timing of the multiparametric MRI. We did a multiparametric MRI 25 days after the surgery. Once you get a patient with a diagnosed prostate cancer in your OPD, the patient is also in a hurry to get the treatment. And somehow the surgeons also have this, it's very difficult to keep your hands off the patient. And somehow we ordered a multiparametric MRI about 25 days after the surgery. As I can show you from the literature, this is one study I found, the accuracy of tumor localization for MRI interval, depending upon the day on which the MRI is done. And if you do it within 3 to 4 weeks, the specificity of the MRI goes down significantly. So MRI was probably not worth the time which we spent on it. Second problem was how long after TURP did we do the surgery? We did somewhere between 4 to 5 weeks after we had done the surgery, and we had done a nice urethrovesical anastomosis. I could show you again the kind of bladder neck which I had developed. But the problem with the post-TURP radical prostatectomy is that the prostatevesical junction is difficult to dissect. The UV anastomosis becomes very rigid. Bladder reconstruction may be required because of the fibrosis. Posterior dissection is difficult, and there is risk of anastomotic leakage and incontinence is increased. Therefore, I found this one study from a Chinese study was there that they recommended performing surgery either during the first month after TURP or to wait until 4 months after TURP. So the anastomotic dehiscence is not very common after a radical prostatectomy, but it does happen in about 2.5, in about 0.2 to 0.5% of the cases. It is a dramatic complication, especially after a robot-assisted laparoscopy. Main cause is usually either due to a change of the Foley's catheter or because of bleeding, and in some of the studies, no cause was found. Typically, it occurs anywhere between from the second to the 23rd day after surgery, but typically it tends to happen in the either in the very early period or in the late period after the surgery. So how I managed the situation, I did a fluoroscopic repositioning of the catheter after cystoscopy. I put in the catheter into the bladder. You can see this is a cystogram after I had inserted the catheter into the bladder, and now the Foley is seen lying well inside the bladder. And the next question was then how long to keep the catheter. We went back to the literature and we found that any time between 2 to 6 weeks is a good time. So we kept the catheter for 6 weeks. So after, for about a month. So the catheter was kept for a month. After removal, he voided well. He had minimal incontinence. One diaper was used, and it was mostly a stress incontinence. And you can see the uroflow which came out of this. So this is what happened about a few days after we had removed the let me just rewind. So this is what happened. What happened that after about 9 days after we had removed the catheter, there was a severe bladder neck stenosis. The bladder neck was obliterated. I wanted to show you in the video the insertion of a. So you can see the bladder neck in the video, which is starting to work over here. And I will be able to pass a guide wire very nice, just very snugly. It went inside the bladder, and now I was with a situation where there was a urethrovesical stenosis was there. So I did a dilatation, and I came out, and and this was the uroflowmetry after the dilatation, and I was keeping my fingers crossed that perhaps this will pass. But another 10 days later, and his uroflowmetry dropped significantly, and he was hardly any outflow was there. He came back again almost in retention with a very poor flow, poor outflow. So we did a bladder neck incision. We did a laser BNI. The laser BNI, I hope the video is clear. It's stopping somewhat over here. And this was the bladder neck at that point, and we used a double Mercedes Benz or star shape, multiple small incisions all around the bladder, very short. And we came out after making these multiple incisions with a wide open bladder neck. And this was his uroflowmetry after the bladder neck incision. All in all, what happened after 6 months, he had a PSA of 0.040. He was continent, and he had just started intercourse. He had an intercourse about a week back, and he was quite satisfied with it. So what had happened, according to me, the first mistake was that the original doctor had ignored the PSA and he had gone in for TURP. Mistake number 2 was that the MRI was not reliable at the time when we had done it. And mistake number 3 was that we did an early RP after the TURP. We could have waited a couple of months more so that the fibrosis could have settled. What I think happened was because of the resection TURP, the bladder neck also was resected and it was very thin. And when we did the suturing after the TURP, the bladder neck gave way after the surgery. The management is usually endoscopic realignment as early as possible, and if the BNI has to be done, bladder neck incision should be short and shallow and multiple. I like to point out that the rupture of anastomosis is not usually related to such an experience, and that is how I excuse myself. So RARP after TURP has high incidence of anastomotic complications. Anastomotic disruption is rare, but a dramatic complication, and the reason is not clear. And it is not clear whether to manage conservatively or aggressively. Thank you very much for your patient listening. Hello.
Thank you very much, Dr. Sood. That was an excellent presentation. We go ahead with the next presentation from Dr. T.A. Kishore. He would be talking about bilateral ureteric injuries in a register-sparing approach. Dr. T.A. Kishore.
Yes. Can you hear me?
Yes.
Okay, perfect. So I'm going to share my screen. There we go. Can you see the screen?
Yes, it is seen perfectly.
Okay, so this is a case of low volume, low grade prostate cancer. It happened about 3.5 years back. And I was in my early days of research sparing. And it was my 19th case at that point. Okay, and it was mostly a BPH, a low volume, big prostate. So I started dissecting. See, the bladder is on the top portion, and the prostate is on the I planned to open the urethra, but what happened was the bladder got opened, so it caught me by my surprise. So my intention was to get beyond that, to get across that. You see, the bladder is on the anterior side. I was trying to get around the urethra. So I tried several maneuvers. As you know, the research sparing can be sometimes frustrating, especially in the earlier days, because it's got quite a steep learning curve, and you're taking a step backward from your routine prostatectomy and then doing it. So anatomical perception is poor as far as research sparing the initial part. So again, I tried like going around the bladder. I was not able to go. So again, see, and then now I'm opening the bladder at another portion. I just can't get around to the urethra, so I start cutting. Again, I'm opening the bladder more, trying to get around the bladder to get to the other side. Still, so I'm completely lost. If you see anatomy, it's kind of distorted. So now the bladder, there's a large run in the bladder, but somehow I found my way out. I did research sparing prostatectomy itself. So I'm cutting here something, you can see that with the cautery. So you can see something is retracted back just now. So see the catheter here, the bladder is widely open. I did a research sparing itself. Somehow last ground, I just managed to come on track. And but then to my surprise, this is a large bladder with the left ureter injured. You can see that ureter is draining urine. It's outside the bladder. And to make it worse, the other ureter was also injured in the next one. See, this is the ureter right there. So I cut both the ureters. In the process, I have a large bladder neck with a kind of trigonal disruption. So what happened? I mean, again, it's quite surprising to do that. So if you see, the only mistake I did here was everything was going fine. One, I stayed a little bit away from the bladder, which is again acceptable if you have a higher grade cancer. But for this, probably I should have kept very close to the prostate. And see, I asked my assistant to hold the seminal vesicle. In fact, that is not being done by even Kundra or Dr. Ravel. They hold by themselves. So assistant is holding and he's skewing the prostate. He has held the prostate more towards the left side of the patient. So that is why I was not like seeing the midline. I lost the midline. So I was like left to one side of the bladder. So in that way, we'll never see the urethra. I went on making the bladder rent. So this is the same clip. See, because I'm never going to see the urethra because urethra is not seen because the assistant is holding with a laparoscopic grasper and he's swaying onto the one side. So I think in initial period, probably if you're not sure of the anatomy, probably at this point I should have converted to the anterior approach rather than persisting with this. Because as you know, as you can, from the video itself, we can assume that I'm pretty lost here. And you saw that I cut a tubular structure in the previous video. That was the left ureter. The right ureter, even I didn't know, like even I went back, I couldn't see that like I cut the right ureter. So, I mean, from a simple prostatectomy of 2 hours, like now I'm like probably dealing with a larger surgery, a highly morbid surgery. See, this is the left ureter. In fact, I'm cutting that. So I'm grabbing it and cutting. So it gets retracted. So just getting retracted. So and that is how it happened. So subsequently, because it was a bladder was very large, I could not close from the Ratchet sparing. I made the anterior approach and then like tapered the bladder neck. I did the tennis racketing of the bladder neck and then sutured the bladder neck to the prostate. Just like in a regular anterior approach. So, and then I filled up the bladder. I did bilateral ureteric reimplantation. And non-refluxing, because by that time I was tired. I lost. So a non-refluxing type of ureteric reimplant was done. So this is on the right side. Because the bladder had to be filled up and a stent was placed. On this side. And this was on the left side. The right side and coming to the left side. So the right ureteric reimplantation is being completed. And the same was done on the left side. So I think the lesson is that, I mean, I think the caveat is that in the Ratchet sparing, probably when you're attempting, when you're not sure of the anatomy, better to convert it to more familiar ground to the anterior approach rather than meddling around. We had a margin negative. We kept the catheter for 14 days. Stent was removed after 6 weeks. PSA is undetectable, but still patient uses pads. I think probably because of the trigonal disruption. About it's almost 3.5 years now, so still using. Thank you.
Thank you very much, Kishore. An excellent presentation. A lot of learning points. I'm sure there will be a lot of questions, but before we take the questions or answer the questions which have come on the chat box, I would like to ask our expert for this session, Dr. C. Mallikarjun, who requires no introduction, to give his comments on what we just saw and how could he have done this particular thing in a better way, or the lessons that we want to learn from these 3 cases. Mallikarjun, sir. Unmute, sir. Unmute, sir. Unmute,
Okay.
sir. Yeah. Yes.
Unmute.
Yes, sir.
Yes, yeah, that's it. Okay. Thank you, thank you, Arvind. But one thing, it should be everyone will go through this sort of a phase one day or other. But the only thing which we need to learn backwards is introspect, as what Sopan was telling. I'll look at 3 cases. Number 1, Ankit was very clear in saying, number 1, he's a very thin patient. Whenever you have a very thin patient, the chance of you puncturing across into the retroperitoneum is very high. So convert, and whenever it's thin abdomen, very small abdomen, you are able to feel the aorta on it. Please don't try these things. Number 2, colonic perforation with a varus nothing happens. You take a serosal stitch, you come out, nothing is going to happen. You don't need to worry about a colonic perforation with a thing. What you have done is, most of these things, most of these retroperitoneal pneumoperitoneums the air starts leaking, the carbon dioxide gas starts leaking at some vents in the peritoneum, in the peritoneum, posterior peritoneum, and the pneumoperitoneum will get established over a period of time, and the retroperitoneum, pneumoperitoneum will start getting compressed. So It's ultimately, you'll be entering into the peritoneal cavity only, but the only thing is you got a lot of air inside the retroperitoneum, which doesn't make your dissection very palatable or a little irritating to you because of lot of bubbles there. All these patients should have one chest X-ray in the post-op because pneumomediastinum is very likely in these patients. With a positive pressure and a high pressure, what you use, pneumomediastinum is one possibility which need to be seen. Very unlikely to have an aortic injury with a varus needle. The major vessel injuries are mostly onto the right side with an IVC, which can happen, but not usually with aortic. The one point which is very good is the more the number of attempts, higher the chance of injury. I think if you have 2 attempts, possibly look at an open technique, which as suggested by you is an excellent thing. And most common reason for this sort of a problem to happen is poor muscle relaxation. There is a resistance which happens at the level of muscle, and that will produce the needle or a trocar to go beyond a point than what is expected to be. That is my observations in the first case. The second case is Sopan. I still feel it is nothing but, you see, you had a case wherein you had an anastomosis, the anastomosis worked well for the next 10 days. That means what? The tissues were intact till that point of time. And then you started having a collection in the pelvis, not an urinary ascites, a collection in the pelvis. That means it is almost 7 to 8 days later or 6 to 7 days later, the leak has happened or the disruption has happened. That means the thinning of the trigone, which you have pointed it out during a TURP, especially with the median lobe, and you using that a epithelialized trigone as a way to anastomose, that would have been the most likely thing. And you had what? A little muscle and more of a fibrous tissue, which will give away over a period of time. So that is most likely the reason why the whole thing sloughed off on the 7th or an 8th day. And then there was the collection and the disruption was there. He never came with a urinary ascent. It was catheter leak, a collection which was draining by the side of the catheter, which was already always happening. And the one part of the balloon got outside into the cavity, and still the tip of the catheter was still lying inside the bladder was the most likely reason. That is one thing. So whenever you do a trigone, whenever you do a radical prostatectomy in a post-TURP scenario, I would say excise a little amount of it area. You will find a clear demarcation, especially if it is done in a long time. Like 2 years later, if you do a TURP, nice cavity, you'll find a nice demarcation between. Very early demarcation will not be there. Like especially after you've done it after a month or 20 days later, you will not find that demarcation. And everything looks epithelialized, but in fact, it is not so. So that would have been the problem for you. And I would say, bladder neck contracture is imminent in absence of a mucosa to mucosa anastomosis. There is no doubt. I can say you're lucky that your multiple incisions are worked, but I don't know how far they will work and how long they work. And I think possibly you need to think about an alternative, how you need to manage in case he comes back with a bladder neck contracture again. Coming to Kishore's case, I feel he's lucky at the time that he recognized it on the table. Majority of the times, by the time you're vexed and also as if the holes in the ureter were never seen. You saw some urine, which is very unlikely to see most of the time, because most of the time patient is dehydrated, some element of low fluid will be given. So you may not see any fluid, and mostly it is picked up post-operatively. But you're lucky, and your persistence in looking into the ureters at that point of time paid you off at that time. There are 2 things most likely to happen when you try and think about this sort of a thing is getting into the prostate in anterior to the seminal vesicles, thinking that you have reached the bladder neck still further. That is one possibility, wherein you resect into the prostate or dissect into the prostate. And the other thing is keeping much away from the bladder neck, thinking that you're reaching onto the prostate and getting into the trigone, which is the 2 reasons. I would say the only thing which I didn't observe you at that point of time is usually you tend to do one balloon inflation and collapsing, which can be done once or twice to make you feel where exactly can be the bladder neck, so that you restrain in that place, which I didn't see that maneuver, possibly got edited. Possibly that is the reason why possibly we missed it at that point of time. But anyway, you went away on it across getting into the identified the problem, and that's the best way you could manage the anastomosis and reimplantation. I don't think anything else anybody can do. But at the same time, whenever you do REDGS, I think if you take any data, all REDGS sparing prostatectomies in the first 10 to 15 cases will have some complication or other of some reason or other. It's quite common. That's quite common because it's technically challenging and difficult case to do for anybody to do it at the going. Thank you. I think I've covered the points, whatever it is there, and that I don't think that
Yeah,
nothing more than that. If there is anything, please.
I think you have covered almost all the points. All are very pertinent points, and those words of wisdom. I think you have made out those points in each and every of those cases. We are really short of time, but I think we'll just take one comment from Professor Anand Kumar before we go to the next session.
This is about Sopan Sood. It's very interesting case. One thing, like you said about the multiparametric MRI. See, when the patient you have seen that already diagnosis was made. So that time MRI is usually done to see any extra prosthetic growth, seminal vesicle involvement, and the lymph node, which you will see even at that time. Second thing, I'm just wondering that I don't know whether it is right or wrong. Like you could see that bladder was distended. So like if you put a trocar cystostomy and ultrasound guided drain the urine, or even just do the trocar cystostomy, let it settle, and then try, probably infection will go away, collection will go away, and then probably things might be better. I don't know. Like I would have, looking at that, I thought probably I would have tried that way.
Yeah, I think, sir, that is there are different ways of bathing the cat, but I think your point is very well taken. Thank you very much, sir, Mallikarjun sir and Anand Kumar sir. We go to our next session, that is on female urology. We are having three. We'll be seeing three complications. One is recurrence after female urethroplasty, if Dr. Nikhil Khattar has joined. Then we are having laparoscopic salvage of VVF with neovaginal reconstruction. And then finally, and very interesting 8-minute session from Dr. Anita Patel, wherein she lets us know what to do when the tape goes where it should not go. We start with Dr. Nikhil Khattar, if he's there in the webinar room. Dr. Nikhil? Okay, so we go to the next talk by Dr. Rishi Nair on laparoscopic salvage for VVF associated with neovaginal reconstruction.
Okay, thank
Rishi,
you, Dr.
yes.
Yes, thank you, Dr. Ganpule. Well, I would like to thank the USI, especially Dr. T.P. Rajiv and Dr. Anand for making me part of this program. So, are you getting the slides now? Is my screen visible?
Very nice.
Yeah, okay. Okay. So what I'm going to present is basically a laparoscopic salvage of a vesicovaginal fistula, which occurred during the neovaginal reconstruction in a patient of MRKH. Now, you know that MRKH patients are really unfortunate in that they don't have any vagina since birth, and uterus and fallopian tubes may or may not be present, and the ovaries are generally present. The options for these patients are generally Macindo's vaginoplasty, where the space is created in between the urethra and the rectum, where the vagina should be, and then that space is just kept open using dilators, and the epithelialization is done by doing grafting, either skin graft or the amnion graft can be used. And the other uncommonly used options are the Davidoff vaginoplasty, where the peritoneum is used as the graft, and the intestinal neovaginal reconstructions that can be used. But as you know, because the space is very limited and the rectum is actually tented above because there is no vagina in between the two structures. So therefore, the creation of this neovaginal space is very important. And during this creation of the space, it is likely that one may enter into either the urethra bladder or onto the rectum if one goes too close to the either structures. So this is where we can enter into the bladder or the urethra and create a iatrogenic urethrovaginal fistula. The other ways when where this fistula may form are either the because this neovaginal reconstruction is only a thin cell layer. So therefore, when the patient is continuously and repeatedly using the vaginal dilators, again, this area is prone to disrupt because only directly the bladder wall and urethral wall is there underneath the single cell layer of the amnion or the skin graft. And thirdly, the erosion can happen because in some patients where the uterus is there, the Mallicott's catheter is placed long term, and then this catheter can gradually erode through the cervix and create a fistula formation. So all this can happen for this fistula. Unfortunately, I don't have the video for when the fistula occurred in this particular patient. So the options whenever the fistula does happen are very limited in this patient. Already the patient has loss of neovagina. So either one of the option is colpoclysis, which means that the patient would have to live without a vagina lifelong, or the other options are use a vascularized vulval tissue flap or a fasciocutaneous flap from the thigh, as we use for the stricture urethra patients, the cripple patients. But all these techniques would lead to mutilation of the genital and local upper thigh area, which is not cosmetically good for the patient. So the other best option is the enterovaginoplasty. But the enterovaginoplasty is actually a major surgery which involves use of using the bowel, and some patient may not like the continuous mucus discharge that may happen with use of this, but ultimately it does provide a good vaginal length and width, and also it can be used as a salvage technique for the fistula that becomes a major problem for these patients. So this was the patient who came to us after about 4 months after having undergone that surgery outside, where the blind instrumentation and new vagina was being reconstructed, and the surgeon happened to enter into the bladder neck, and the proximal urethra got eroded. So what we did was basically we did the lap assisted sigmoid neovagina, but because the proximal urethra and bladder neck were also eroded, we simultaneously placed the pubovaginal sling also in this patient. What I'm going to show you is only the laparoscopic neovaginal reconstruction. So as you can see, the distal urethra was seen 1.5 centimeter. This was the long fistula which was there involving the bladder neck and the proximal urethra. The original vaginal dimple was there. And then we proceeded by creating the space proper. As you can see, the entire limb of the sim speculum can be seen in this space, which would be used for the neovagina. So then the patient was placed in the low lithotomy position. The first 10 mm port was placed about 3 to 4 centimeters above the umbilicus. Another port was placed in the right iliac fossa far down lateral, and another 5 mm port was placed in the left iliac fossa. So we proceeded with harvesting the sigmoid. The sigmoid mesentery was opened up on the lateral side, high up till the splenic flexure. And then the gonadal vessels were preserved. One has to keep medial to the gonadal vessels and the ureter. The ureter, you can see, the entire mesentery of the ureter should be left with it. And similarly on the right side also, the peritoneal incision is given over the promontory, keeping the ureter on the lateral aspect. And then the entire sigmoid mesentery is lifted up from the sacral hollow. So you can see that the entire sigmoid, and now we are reaching up to the rectum also. The rectum must be dissected till the junction of the mid and the lower third. This is important because if we end up cutting the rectum high up, the sigmoid loop may not be able to reach down into the perineum. So the lower the loop, the better it is. And proximally also we have to dissect till the inferior mesenteric artery origin. So as much mobilization that is possible for the sigmoid and the rectum, that is done. And after that, the endo cutter stapler is used to cut the rectum at its lower 1/3 and mid 3rd junction. Sometimes because it is thick, one may require double firing. And after that, the loop of the sigmoid is pulled out by making 2 to 3 centimeter incision in the lower abdomen. And then a 10 to 12 centimeter segment of the distalmost sigmoid and rectum is harvested. The distal end stay suture is taken for better orientation. And in the descending colon, the anvil of the circular stapler is inserted using a purse string suture, and then the bowel is pushed back. So after that, the other half of the circular stapler is passed through the rectum into the anal canal. And then the circular stapler, one should see the orangish plastic covering. Here you can see that. And then the two parts are hitched together. A click sound is heard, and then the stapler is fired. So this would complete the anastomosis. So after that, the peritoneal side of the space is also created, as you can see. And both the sides, it is joined together to complete the space for this new vagina. And the isolated sigmoid loop is harvested down. It can be isoperistaltic or it can be antiperistaltic, it doesn't matter. And the proximal end is then fixed to the promontory so that it doesn't prolapse. And then it is extraperitonealized. So once this is done, a drain may be placed and the lower end of the bowel is fixed onto the introitus, and it provides a layer for the fistula also, and also provides the neovagina. So we have done 5 such cases as of now, and 3 of them had fistula repair also at the same time, and none of these patients require regular vaginal dilatations as of now. So just to conclude, this urethrovesico-neovaginal fistula has very limited options for repair because there is no native tissue of vagina that is available for any reconstruction. And antrovaginoplasty is a very good option in these cases, and laparoscopic approach would provide the benefits of the minimally invasive surgery. Thank you.
Thank you, Dr. Rishi. You have so nicely brought out all the points. We'll take the comments from the experts after we finish all the 3 presentations. Thank you so much. We go to our next presentation by Dr. Anita Patel. Dr. Anita, can we go to your presentation? Dr. Anita?
Yes, I'm just sharing my screen. Just give me a moment.
Thank you, madam.
Is it visible, Arvind?
Yes, very nicely, madam.
Okay, good evening, friends, and thank you so much for asking me to share my little experience in dealing with the tapes, especially now that the world is woken up to the amount of damage that tapes can be doing if they are not inserted properly. So I've got a collection of cases which I wish to share with you all today. Just a moment. So there are a few terminologies that we need to understand. And when we're talking about erosion by a tape, it usually refers to migration of the entire tape or a part of the tape into either the bladder or the urethra with superadded infection. When we talk about exposure, this usually refers to vaginal exposure of the tape. We don't talk about exposure in the bladder because exposure means exposed to the outside. How do we diagnose it on tables? So with few line diagrams, I've made an attempt to show how both in the transobturator as well as in the transvaginal route, the tape can actually enter the fornix or the urethra. See how close the tape is and the amount of distance between the vaginal lining and the urethra, which is shown as a little circle. So the 2 line diagrams in the top half of the image show the normally taken route by both the transobturator tape in the left half of the screen and the transvaginal tape in the right half of the screen. In our attempt to place the tape very, very close to the vaginal wall, we sometimes actually traverse the vaginal fornix. The risk of this is pretty high in both transobturator as well as transvaginal. Should this happen on table, you simply either withdraw the trocar, reinsert it, or if it is accidentally diagnosed on table at the end of the procedure, you simply pull the two edges of the vaginal mucosa onto the tape and sew it together, and things should usually fall into place. So let us see if we injure urinary tract during the tape procedure on table. If the bladder injury is noticed, bladder is a very forgiving organ. Simply remove the trocar, pass it again with due care. I'm not going to go into the operative details here, but there is a bladder retractor used, bladder deviator used during the vaginal tape retropubic route, and that ensures that the bladder is placed away from the operating side. The same is believed not to be required during TOT because the TOT works in a much lower plane. However, the urethral injury chance is much, much higher during transobturator tape. And should that be picked up on table by a very vigilant scopy, it's best to abandon the procedure. Cortical injury is the least harmful. In last about 10 years, we've seen 14 cases, out of which 2 were our own cases, and both were vaginal erosion stroke exposure, because one of them had a little bit of added infection in the vagina, but neither needed any aggressive treatment. We removed the portion of that vaginal exposed tape, and I'll show you the operative video of that. The other 12 cases were operated elsewhere, and I'm sharing my experience with those 12 cases, especially some of the videos where it's been a learning curve for us. So if the case is present late, it can happen in either TBT or TOT. Usually, if there is superadded infection, you will see purulent discharge. Patients will present with storage symptoms which may respond to antimuscarinic. But if there are persistent storage symptoms, an alarm bell should go. Urethral pain is a bad sign. And if somebody persistently complains of urethral pain, either you have placed the tape too tight or the tape may have actually traversed the urethra. Persistent hematuria, another bad sign. Any hematuria is bad sign, except during the first day or two, especially if the tape had accidentally gone through the bladder, which is usually not a big deal. We simply move the trocar and place it in the right place, and such people can have hematuria for a day or two. But if there is persistent hematuria, think that you may have breached the continuity of the urinary tract. Anybody with persistent slow flow would mean the tape is probably obstructing, and anybody with a fixed calcification in the urinary bladder is a bad sign. Now, this is a lady who had had a transobturator tape done 3 months back. And in the post-operative period, the incontinence remained the same, but she developed persistent urethral pain. As I mentioned, this is a bad sign, and this is within the first 3 months of the surgery. So let us see what this video shows. We had done a sonography, which was a transperineal sonography. Okay, this is a cystoscopy where we are entering the bladder. It's done with a female urethroscope. So that has a very, very short tip, and you are able to visualize the entire urethra very nicely. Female urethra in a 45-year-old lady is not going to be very long. This was about 2.5 centimeter. And of course, as we all can see, at the roof is the calculus, which was picked up on sonography. This was 3 months after the surgery. It's difficult to believe that this was erosion. As we withdrew more and more, it was as if more and more tape portion was spilling into the urethra. Now, this usually happens if there has been intraurethral placement of tape. You don't get this kind of erosion more at the roof of the patient's urethra within 3 months of the procedure. What did we do? We simply removed this portion using laser, and everything was very clear for about 6 months. And then she came back with again repeat symptoms, again repeat scopy. We did this twice. This is the same patient at the bottom where vaginoscopy was done, and a part of the tape was exposed even in the vagina, which was deep, high up in the fornix. And this was removed using open surgical technique. So far, we have done 3 lasers in this lady over a span of 1.5 years, simply because she wanted minimally invasive approach. And each time the tape seems to be prolapsing more and more into the urethra. So finally, 1.5 years after the first surgery, we removed the entire tape. A subsequent check scopy has been fine, and needless to say, she's totally incontinent. So now we are planning to do a pubovaginal sling in this lady. This is the vaginoscopy which I'm sharing. So this is the second lady. If you look at the top video, she had again had surgery done 1 year before she presented to us. Intense urethral pain and very slow flow of urine. The flowmetry showed a very, very slow flow. And the transperineal sonography, the translabial sonography showed foreign body in the urethra. I was unable to enter this lady's urethra. And in fact, I kept on staring at the urethra. The flowmetry was like a male stricture. And if you look carefully, again, this is not a tape which is eroded. This was the tape which had gone through and through the urethra. And it took us a long time to make out where the opening into the bladder was. We did all sorts of tricks, finally decided to place a glide wire which somehow entered the urinary bladder. There was some calcification also, as is apparent. And I was amazed that this woman was actually passing urine at all. So we placed a glide wire, as you can see that, and then later on did gentle dilatation over the glide wire. You can actually see the correct path going below that, going underneath that. And in order to enter the bladder, we had to actually clear this tape with laser. Now this case, it was very interesting that we did only one laser and her urethra stays entirely free. And she's been free for about a year. During the procedure, we had to use a grasping forceps. Now, these things in a female urethra are tricky because the length available is too short. The standard operating cystourethroskop does not allow us to visualize it like an end view. And sometimes we have to use one of the older ureteroscope with a large ureteroscopic forceps in order to pull on the tape. But this patient, we were successful and we didn't really have to do any conventional open surgical technique. This is a third lady, vaginal exposure. TVT was done 3 years back, and she had presented with dyspareunia and postcoital spotting. This is the video. This is quite an easy procedure. It's not as messy as the erosion in the urinary tract. All that you have to do is simply hold on to the piece of tape with an ordinary hemostat, pull it down, remove only the exposed portion and sew the vaginal edges together. This is the simplest part. Here a lady had undergone a procedure which was a conventional STEMI procedure several years ago, continued to have hematuria, and she was in a village kind of place and she had never had a sonography also. The sonography that we did showed that there was, of course, a foreign body in the bladder, and a plain X-ray KUB shows the bolsters of the STEMI needle. And the video at the bottom, I'm just going to skip that to the end in order to show you the exciting part. So the bolsters are in the bladder, and we had to use laser to excise the portion of the STEMI stitch. But as we were pulling on that, we realized we could not pull on that because it was pulling in the groin. And then we explored the groin at the same stage. None of these patients, we actually did any simultaneous urethral anti-incontinence procedure. This lady, in fact, we waited for 2 years, did a repeat scopy, did a repeat sonography, and then did a conventional tubovaginal sling. And the last case is something which has really taught us a lesson, SUI since many years, and she had had 3 synthetic tapes inserted, all done elsewhere. Each year she was getting a new tape inserted. She presented with urethral pain, total urinary incontinence, very thin patient. Remember, if you do a TVT in a thin patient, chances of you injuring the surrounding organs are that much higher. Exactly like how the laparoscopic case we were discussing earlier, we've got to be very careful putting the TVT trocars in somebody who is very, very thin. Far easier doing it in a chubby or a well-padded patient who has a lot of fatty tissue to protect. So in this lady, the tape had eroded the urinary bladder at 5 different places and had also eroded in the urethra. And the 3 tapes had entered the urethra, and part of the urinary bladder had shown multiple areas where the tape had entered and exited the urinary bladder. One of the scariest things that we saw. So what did we decide to do? We decided to do a staged approach. She was totally incontinent, and we didn't really promise her any anti-incontinence procedure. The first part was to remove these eroded portions of the tape. So we did it as a staged procedure. In the first procedure, we removed the urethral tape. And during the surgery, it was one of my first cases of removal of tape, and the entire urethra and the bladder neck came in my hands. And I landed up having to reconstruct the urethra with a Marsh's pad of fat, and I didn't do anything to her urinary bladder. That we unfortunately did not record. We left a suprapubic in situ, and at a second stage, we explored her transabdominally. 3 tapes had gone in that region, and we had to actually excise a strip of detrusor, which was containing multiple pieces of the tape. And as we traced one part of the tape, we realized that it was actually going into her groin towards the iliac vessel. And any further pull would have meant that we would have actually landed up into the iliac vascular area. So all of us know there are certain risk factors in mesh erosion, but from my little experience, what I have learned is many of these unwanted outcomes are actually preventable. And some of the guidelines, NICE guidelines, AUA guidelines, EAU guidelines, all of them mention the correct operative technique and the need for mentoring, but they all also mention that use a tape which has undergone robust trial, use a tape which is monofilament, and also use a tape which is colored because it has high visibility. When you're considering surgery for SUI, it's essential to evaluate all the options, discuss with the patient, and only then select the correct tape. But there is no shortcut to having good knowledge of surgical anatomy, scrupulous surgical technique, and last, and this is something which is often not done even by many of us, and that is we don't do a good urethroscopy. We are good at cystoscopy, but female urethroscopy is not done so scrupulously. And at least 3 tapes that I have seen going through the urethra presented way too early to have erosion as the only explanation. According to me, they must have been on-table injury. We have been lucky that so far we've had only 2 cases, and I hope none of my cases have gone elsewhere. But any one of us can land up having these trouble. Very scrupulous cystourethropy on table. Should the tape go through the urethra, stop the procedure. Don't put any further tape, do it at a later date. If it goes through the bladder, you can place the trocar again on table because bladder is a lot more forgiving than urethra. Any eroded material must be removed. You may be lucky by using laser, but very often you will have to do open surgical technique. Avoid a simultaneous autologous sling, and please counsel your patients. These complications can happen when you least expect them. Thank you so much, organizers, for allowing me to share my experience. Thank you so much.
Thank you very much, madam, for that impressive collection of complications regarding to tapes. And thank you very much for those crystal clear take-home messages. We go to our next presentation. Dr. Nikhil Khattar is here. Nikhil, can you unmute yourself and share the presentation?
Yes, hello, good evening. Good evening, everybody. I'll be sharing my presentation. It is, the topic is an early recurrence after a female urethroplasty. Is it visible?
Yes, it is visible. Yes.
All right. So just to give you a little background, this is a 31-year-old female with a history of poor streams and recurrent infections with urethral pain for last 12 years. Over 12 years, she has had urethral dilatation twice and was relieved for a few months before having recurrence of symptoms. Her uroflow was a very poor flat curve of 6.9 ml per second was the maximum flow. Ultrasound had a thick walled bladder, but the upper tracts were normal. And on her urodynamics, she had a normal compliance with a capacity of 350 cc, but had a P at Qmax was 117 centimeter of water, which was very high. She had a urodynamic obstruction. We got an MCU, and this is what it showed. So so we had a dysfunctional voiding also in the mind. So we took her up for a urethroplasty, and then identified that there is indeed a mid-urethral stricture. and we could not go beyond that point with a conventional cystoscope. This is with a 0-degree scope, and here this much is the so we did a dorsal onlay graft urethroplasty, drop down the urethra, kept on checking where the stricture is, and then did a complete urethrotomy. As I gave the urethrotomy, I realized that the stricture is much proximal. In fact, it was extending till the bladder neck. And I was doubtful of opening the urethra right up to the bladder neck. So the proximal portion, I did it like a dorsal inlay procedure. So incised it, giving small incisions and trying to open my forceps from within. And then it became pliant at some point. And it admitted the Hagars easily. This is where you can see. And after that, I started with the graft. So graft started as an sort of as an inlay there, and then means the portion which was incised from inside. It started as an inlay and then continued as an onlay. I'll tell you that a little later. And so it was fixed here. This is the picture here, the drop down urethra. The graft is nicely fixed here on the bed. And these are the corporal bodies, erectile structures. And here is the retropubic fatty tissue. And then both the edges of the graft were then sutured to the graft. It was sort of 3-in-1 stitch, taking the corporal bodies also. This is the completed procedure. Now, this is the pre-op uroflow. This is the post-op uroflow at 2 months, and sort of successful. It was a bell-shaped curve with more than 25 ml flow, and it continued to remain like that at 3 months of follow-up. But she started complaining of some urethral pain. She was categorical in saying that it is the same kind of pain, although the flow is still good, but the pain is same kind of pain that I used to have earlier. So I did a flow and found that although the Qmax was again 25, but the curve had flattened here. So I repeated a micturating study and found that although the proximal dilatation is not as much, but still it was there. So I did a urodynamics again, repeated. The flow was there, but pdet at Qmax was reaching around 80, and still she had an outlet obstruction. So kept her on, dilated her in the OPD and kept her on CIC. She improved a bit, but again came within a month and started telling that with dilatation it improves, but then I am having symptoms. So I decided to go ahead with the scopy, so which we'll see in detail. So this is in the mid-urethral region. Again, there is a narrowing, which this is means she was last calibrated a couple of weeks before this procedure. Although there is a passage, I've passed a guide wire. There is a good passage, but still probably synecdoche have formed, or there is a definite narrowing, and it is not flimsy also. Doing an OIU in a female urethra requires a little bit more of a control, but can be done. While coming back, we'll see where actually the graft is and what has happened. We'll try to figure that out. If you see, you can start viewing the graft area, which is a little bit different in color. Is the video quality all right?
Yes, it is seen very nicely.
Then only the fibrosis appears. I'm not able to identify where the grafted area was. And when I come out more distally, then I can again identify the graft. So I did not understand what might have caused this, but since there are no standard protocols, how these patients should be followed, how to pick up those recurrences, what to do when you encounter these recurrences. One reason that I could think of was she was very clear with her symptoms that this was pre-urethroplasty. If I do her symptom scoring, it was 10 were her maximum symptoms. After urethroplasty, it became 2. When she was briefly on CIC, it was sort of 3. Just before OIU, it was 6, and again after OIU, she is okay now for 4 months. She is all right. She has not come back, whether it is due to lockdown or whether it is due to relief of her symptoms, but she hasn't even called. So I wondered what could have been the cause. Maybe the clitoral structures only provide the bed for the distal part of the graft. The proximal part is still kept on a fibrofatty area. Whether that is the cause, or whether the graft was started as an inlay and then came as an onlay, probably that was the cause. The other thing, because I have encountered this problem in a couple of more females, and it occurs very early on, as soon as catheter is removed, and usually they have flimsy strictures. This lady had a dense recurrence. So the third thing that I can figure is that probably because the entire female urethra is sphincter active, and unlike male urethra where you place the graft and urethra is stitched to the edges of the graft, urethra is all passive, it doesn't contract on its own. Unlike that, in females, the urethra has a tendency to remain in a coapted form, and that will put pressure on these stitches, and it may form cross adhesion synecdoche, or may altogether exclude the graft, which was probably seen in the middle of mid urethra in this lady. So these are the few causes. So I think probably because of initial pain and all, the spasm will be more, and maybe we should leave catheters a little longer. 3 weeks is what now I have changed to 3 weeks. Earlier, I used to keep it for 2 weeks. And another reason can be that maybe she has some other, although it appears unlikely in this lady now, but maybe some of them have some other underlying cause, and the urethral dilatations itself caused the stricture in the first place. So the symptoms again remain the same, and spasm causes the recurrence. That is all. Thank you. Thank you so much.
Thank you very much. Thank you very much, Dr. Nikhil. We can you stop sharing? We
Yes.
go to Professor Arun Chawla, and he will give his expert comments on these 3 videos that we just saw. Professor Chawla. I think he's not there here. So in the meantime, I would like to ask Anita Madam to just comment on the last video as to what does she think about as far as the reasons for failure are concerned in Dr. Nikhil's case.
So is Dr. Chawla there? Is he?
No, ma'am, go ahead. I'll come after that. No problem.
Yeah, no. My only first comment is congrats to Nikhil, because this was a wonderful video. And I think he offered the explanation, which was perfect. The 3 diagrams that he showed in his last slide, the bottom diagram, which is where he in fact said that the synechiae could actually mean that the urethra closes back to itself with the graft staying superficial to that. And I thought that could be a plausible explanation, because the space available there is very little. The urethral length is very short. And before you realize, you reach the bladder neck. And exactly at what portion you are going to suture, that has a lot to do with how many such cases you've done. So since I don't do this regularly, I think, Nikhil, your video was impeccable. Thank you. Over to you, Dr.
Professor Chawla, you can just comment on the videos.
Arvind, unfortunately, because of my unstable internet, I was not able to see any video except for Madam Anita Patel's presentation interrupted in staggered way. So whatever I know from these 3 videos, I'll just give a comment. It will be general comment. I'll come to Dr. Anita Patel's presentation, which probably I could see for most of the part, but in staggered way. First, I will say it was an excellent presentation. It was not a presentation, but a presentation of presentations, many presentations. What I would like to add in the management of SUI by urologists in the form of tapes, that the madam was talking about the path which tapes takes where they shouldn't go. But sometimes we have to keep in mind before operation also something related to preoperative history, like the previous abdominal procedure and the previous history of any vaginal procedure, which even if the tape goes in right direction, but takes something along in its path and create complications. So coming to first the retropubic urethral tape placement, the first important thing is the catheter should always be in the urethra whenever you are doing the procedure, and most of the urologists will keep the catheter in. Then the use of hydrodissection. If you are a beginner and if you have not done many vaginal surgeries, it's better to make use of the installation and infiltration of saline with or without adrenaline to make a suitable width vaginal flap, which is very important. And in the placement of retropubic urethral slings, the direction is very important, where you have to go towards the shoulder, not to make any extra dissection towards the urethra or towards the pelvic wall, which is very important. And when you are making this dissection, when you are close to the endopelvic fascia, when you are going close, you can keep a guide in the catheter or a mandarin, and this will be pulled by your assistant on the same side where you are putting the guide. And this procedure is always guided. That means when you have made the dissection, you will put the finger. This will guide the needle on the back of the pubic bone, which will always be kissing the bone and coming to the exit point. And I could see the madam stressing about the role of cystoscopy. So when the guide has gone, the cystoscopy with the 70-degree lens with bladder adequately distended, which is very important. All the mucosal force should be flattened. And then you have to look with a 70-degree at 1 o'clock and 11 o'clock. When you have any breach in the mucosal integrity, you will find that some congregation of RBCs or some minor clot coming in your way when the flow of the irrigation is going on. This is a very, very subtle point when you are doing the cystoscopy. And when you are coming out the ureteroscopy, especially with a small pediatric cystoscope or a normal 17-degree cystoscope with a 0-degree. Another important point is when you have placed a mesh below the urethra, or this is pertinent to all the type of whether you are going retropubic or transobturator. And when you are using a branded mesh, Once you have placed the mesh and once you have taken the plastic sheet out of the mesh, don't do any tension on the mesh. Then this mesh should be left in place without doing. We hope that when you are doing this, you are placing some instrument to keep it tension free, not abutting the urethra. But once plastic sheet is out, no more tension on. Then this mesh should be like this only, whether it is loose or whether it is tight, it should be like this only. And very important point, when we are doing a retropubic sling, especially when the patient has a previous surgery, in case of difficulty in procedure, you can make use of a small incision, a mini lap, and get the needles under vision to the desired place. And sometimes you can make use of a laparoscopy if you are not comfortable. Coming to
Professor
the
Chawla, Professor Chawla, can you just make a few more points because we are just exceeding the time?
Okay, fine. So coming to the transobturator is very important. If you are going inside out, you should not go dissecting. 5 centimeter dissection is enough to go to the obturator canal, and make sure how you pierce the obturator canal. That is very important, because if this technique is not correct, you are going to go towards the direction where it should not go, probably injuring the obturator nerve, the anterior division of obturator nerve. Another important thing is, when you are closing the vaginal wound, make sure you are taking both the epithelial margin on each side and closing it properly. If you are coming outside in, is very important that you should come 90 degree and then change the direction. Again, when you are below the pubic bone, let your finger guide the needle into the space, and this space should be just enough for the finger. If you make a too big a space to guide your needle into the vaginal dissection, again it will make the mesh move in and out or away from its desired place in the post-operative period. It's very important again to stress the point, once you have placed the mesh, don't make the mesh put under tension, because all this mesh, when it's exposed, is out of plastic sheath, it just shears the urethral tissue. And it's very important that once it's placed, it has not to be touched. Coming to this, our Dr. Nikhil Khattar's one important thing I couldn't see the video. He was talking about inside and the outside placement. One thing which I wanted to know is the plication of the graft on the under surface of clitoral body is very important. I don't know how it was done, but for me, I have faced this problem where I have seen the whole urethra has fallen down from the roof down. The meatus has taken a different shape. The urethra has become a curved. This was probably the graft which was supposed to stay on the under surface of clitoral body has dropped down. So this led to the stricture right at the site where Dr. Nikhil
No, it was adequately done, sir.
Yeah.
Adequately
So this was one of the case where I faced the problem. Again, I don't know how you managed, but my point is, wherever I have seen a two dorsal, where I have failed, I have gone to a ventral approach. In one patient, I have used the graft, and in one patient, I have used the flap. The advantage with the ventral is it's more comfortable. I can incise the inguinal wall. I can go up to the bladder neck with a catheter placed in the through the urethra. I can mark the bladder neck. I can go. It is very easy for me if a patient who has got a failure of a dorsal only buccal graft urethroplasty in female, ventral becomes a very easy for me. In both the cases where I use the graft and where I have used the flap, I have got no issues in the post-operative period. Yeah. And coming last to the
Sir, you can give the last comment so that we can wind up this session, sir. Yes, sir.
Yeah, I think this what Dr. Rishi has presented is a very rare case of MRK, and probably he has shown the sigmoid colon, and probably is the best substitute for making the neovagina. But only thing with the sigmoid colon is what happens is with the time, the colonocytes, they have their nutrition derived from the fecal stream. The colonocytes don't thrive on the blood vessels from the mesentery. So you find a lot of changes happening in this new vagina because of the use of sigmoid colon, the metaplasia, the hyperplasia, the inflammation, and leading to malodor, and leading to the persistent inflammation in this. So any procedure on this later in the form of dilatation, the postoperative period, it leads to complication. That's what I have recommended to make. Yeah, thank you very much.
Thank you very much, Professor Chawla. We will just go to the next session.
Can I just make a very short comment for
sir,
the
just small quick comments, sir. We are half an hour behind schedule. Yes, sir. Go ahead.
Dr. Nikhil, to
Yes,
do the OIU, it is very, I have published it. You use the pediatric resectoscope or pediatric OIU and your vision is good, you can cut accurately.
Yes.
Thank you so much, sir, for that comment.
Journal of Urology.
Thank you very much, sir.
Thank you.
We go to our next session, that is the most awaited session, that is on transplantation. And we have got three experts, Dr. Ajay Oswal, Dr. Pranjal Modi, and Dr. Anish Srivastava. We go straight away to Dr. Ajay Oswal. Dr. Ajay Oswal, can we start the presentation? Unmute yourself, sir. Dr. Oswal?
Yes. Am I visible and audible now?
Yes, both. You are visible as well as audible. You can start.
Respected teachers and dear friends, good evening. I thank USI and Dr. Ganpule for giving me the opportunity to be here. I present a case of calculous anuria in a kidney recipient. This was a This was a 28 years male who came with anuria of 2 days duration. He had undergone a kidney transplant 2 years ago. No abnormality was found on examination, but his images showed hydronephrosis, hydroureter, and calculus in the ureter and renal pelvis. He had azotemia and hyperkalemia, which necessitated one session of hemodialysis. After one session of hemodialysis, an emergency double J stenting was done. This resulted in normalizing his parameters and the patient became comfortable. After he was comfortable, he was evaluated again. This is the plain non-contrast CT scan after DJ stenting and patient was comfortable. This is the CT scan which shows stent, calculus, and one calculus at the lower end of the graft ureter. So stented successfully, and now we are dealing with 2 calculi in the graft ureter. After patient was absolutely all right, we took him into the theater with aim of doing RIRS. But before that, we evaluated the previous records and found out why these complications and how this complication has occurred. The donor's preoperative CT scan showed a 7 millimeter calculus in left kidney, and with lot of deliberation, we had chosen to retrieve the left kidney and transplant the left kidney as it is without doing anything to the stone. So this resulted, against our expectation, this resulted in calculus anuria 2 years down the line. This is an attempt to do an RIRS. You can see that this is the stone, and we are trying to push in a RIRS access sheath. But because of the presence of stone, this access sheath is unable to enter the ureter. So we change our track then, and we parked a ureteric catheter in the upper calyx, opacified it with the contrast, punctured it, and achieved a through and through guide wire. One end of the guide wire was out of the anterior abdominal wall, through the PC system, down the ureter and bladder, and out of the external urinary meatus. So now we wanted to change our approach to antegrade approach from the retrograde approach. So we took the antegrade approach. This time, dilatation, but there was a jerk here. This was an abnormal movement which made us think that something is wrong. So we put a contrast here and realized that there was some extravasation here. So at this stage itself, we decided to abandon the procedure and just put in a PCN as well as double J stent. The bonus, of course, in this step was one calculus has slipped down into the bladder. The same calculus which was not allowing my RIRS access sheet to enter the ureter has dropped down into the bladder while I was doing the PCN. So one calculus in the bladder which was removed cystoscopically and one calculus still remaining in the ureter or pelvis. 6 weeks later, we took him up for antegrade flexible ureteroscopy. This time we could pass the access sheet right up to the stone. This is the stone and this is the access sheet. We pulverized the stone with holmium laser and all the fragments were pushed down the ureter into the bladder. Is my video clear?
Yes, it is clear, sir.
So this stone was pulverized and all the fragments were pushed down into the bladder. This is the view of urinary bladder from the antegrade approach through the upper calyx of the graft. This is the Foley balloon. You can see the native ureteric orifices and all the fragments have been flushed down the ureter into the urinary bladder. These are the fragments and they were flushed out, and this is the post-op check X-ray KUB which shows a stent and there is no stone. 2 years after this procedure, he is absolutely all right. His creatinine is 1.3 and he is on cyclosporine, azoran and omnacortil. His hypertension is controlled with one medication, that is telmisartan, and he was doing fine. So we, before undertaking this transplant with a stone bearing kidney, we had done a lot of deliberation and we pounced upon this reference wherein the authors have studied 325 living donors at one center, out of which 24 donors had stones. 11 recipients were transplanted with graft containing stones. The stone size in this series was 1 to 9 mm. And out of this, 10 recipients reported no complications. And only one recipient later on had obstructive nephrolithiasis, which also was managed by PCN, followed by conservative treatment, and the stone was passed out. 5 patients were transplanted with grafts without stones from the donor with stones. That is, the stone-bearing kidney was left into the donor. So there is literature which supports that you can transplant a kidney bearing small stone without doing any intervention to the stone if the stone is small. Again, similar to our case in under discussion, there is one reference wherein transplanted kidney has undergone mini perc with laser lithotripsy. So this was a dreadful complication, first time in my career, which we could manage successfully. Thank you very much. I thank the Urologists Society and Indian School of Urology and of course Coronavirus for giving me this opportunity. Thank you very much.
Thank you very much, Dr. Oswal, for that excellent presentation and sticking to the time. I would like, we will take the comments at the end of this session. I would like to ask Pranjal sir to come ahead and present his unusual complications for following deceased donor transplantation. Pranjal sir.
Can you see the slide?
Yes, they are seen very well.
Okay. So I will talk about 2 complications only, and they are the complications during the organ procurement from the deceased donor. So all of us know the standard organ procurement from the donation after the brain death donor is like you do the laparotomy and thoracotomy. Then you mobilize the right colon, duodenal cockerization, division of a small bowel mesenteric attachment up to the ligament of treats. And that gives the complete exposure of the retroperitoneum. Then you ligate the inferior mesenteric artery and go up further to dissect the aorta, vena cava, renal vein, etc. And then finally, one should control the inferior vena cava and aorta. After that, the rest of the thing is done by the liver team and liver dissection, and supraceliac aorta control is done and thoracic organ dissection is carried out. When somebody is doing the, of course, the sequence of removal of organ is first the thoracic organs, then the liver, then pancreas, then small bowel, kidneys, and vascular graft. When somebody is trying to do only the kidney procurement, or when we sometimes go to the center where there is a lot of hurry by the surgeons, they started doing operations and then they mobilize the kidney, and then by the time we reach to procure the liver, the kidneys to be used by that particular center, so they are in hurry in operation. They also think that by doing so, we will minimize the cold ischemia time and so. So what do they do? They do the only laparotomy and then bilateral colon mobilization, bilateral kidney mobilization. So this is the most dreaded thing which is happening, like bilateral kidney mobilization. Then difficulty in achieving the suprarenal control of aorta and sometimes the vena cava, because they have done just the laparotomy. There is no thoracotomy done. And then sometime we have also seen that when it is only kidneys to be procured, an individual kidney procurement like that is happening like that in a living donor nephrectomy. So like just I'll come to see the one such kidney has come when patient was having, patient has undergone only the laparotomy, complete mobilization of the kidney before we reach to the procurement center. And then we saw that they have only one kidney to accept, the other kidney was supposed to come to us. So then the one liver and kidney, when it come to us, we have dissected it out and found that on bench, that this has happened. Like you can see, this is the renal artery with the Carl's patch, and then the very major, the major division maybe is a posterior division, and there was a hematoma in the arterial wall, and you can see the thrombus inside. If you see very careful inspection, like then there is a line of demarcation is seen, even though this kidney is perfused, but here there is a slight line of demarcation shows that it is under perfused, and then that means again the entire procedure is the hematoma has occurred and thrombus has occurred when the blood was flowing in. Otherwise, this would have not happened. Even the injury would have happened, but then the hematoma and thrombosis would not happen. So this is definitely the result of a early mobilization of the kidney, because often there is a lot of stretching occurs while trying to mobilize that particular kidney and leading to the thrombus formation in the major artery. Unfortunately, we thought about the options. It could be thrombectomy and arterial reconstruction, but we realized that there could be microthrombi in this lower pole, and which even though you do the major, removal of the thrombus and repair it, but still the microthrombi and leading to the microcirculation problem. It's a lower polar artery, especially lower pole, less likely that we can get a success into this, and rather than taking a chance, we discarded this particular kidney. So in this particular case, the outcome of the organ procurement was not very good. I will go to the second case. It's a very short case. The donor was 60-year-old, had a severe stroke, and he had a 5 days of ICU admission. And somehow the femoral vein cannulation was done by the Kawa fix for the IV fluid infusion and taking the blood sample. The local team or ICU team probably was not having access to the jugular vein or the subclavian vein or so, or probably they were not intended to do that thing. So we started procuring the organ, keeping the Kawa fix and everything in the same line, and the flow was good. When the IV fluid was given through the Kawa fix, it was very good. So we didn't disturb that at all. The standard organ procurement by laparotomy and thoracotomy was done. While dissecting the IVC, we found that there is a catheter as well as there is a thick wall, and the IVC was full. So there was probably a thrombus inside, and so we didn't want to move now the Kawa fix at all unless we complete the entire procurement. That was decided, and it was not removed since the chance of embolisms are likely. Then organs were perfused in a standard way, and after perfusion, we opened the IVC. And what we can find, we can see in the right image like this, that is the Kawa fix is completely covered by the thrombus. Like you can see the tip of the Kawa fix here also, which is entering in the left renal vein. And you can see the Kawa fix has been removed, and you can see the thrombus in the left renal vein also, which we could take it out. So we could use in this particular case, again, the organ was procured. I don't have the photograph of the kidney. it was nicely perfused, and it was like you are tempted to utilize this kidney. But looking at the thrombus occur and which we could extract even from the major renal vein, there are chances that the thrombus is extended proximally also. And if the graft doesn't function, and then it is and we do not know how long this catheter has remained in the left renal vein. And so it was, we thought that better not to utilize this left kidney, and it was discarded. So right kidney was used for transplantation. I mean, the thrombus was not extending on this side, but the left kidney was discarded in this particular case. So I think the third case is similar to what has been discussed by Ajay. So I'm not going to repeat the same thing. Just I'll show the picture of it. Like this, a dual kidney transplant. The stents were placed here. We had there was a stone in the second kidney. That is, and then we put a stent, and it was migrated. Subsequently, the stone was migrated also in the ureter. However, we were lucky. We thought that we can give lithotripsy. We give the lithotripsy. Stone fragment obstructed the ureter, and there was a moderate hydronephrosis hydroureter. What is important is we waited for a few more days. In this case, like patient was admitted in the hospital only. The options were explained: PCN, flexible URS, and conservative. Fortunately, within 3 to 4 days time, the patient has passed on spontaneously, and that was all over. So the message is that the patient, we can transplant the kidney with the stone, but you have to be very careful about the definitive management of it afterward. It is prudent to do the management of the stone before you transplant the kidney in, because and that you can do the on table, the semi-rigid ureteroscope also, where kidney is outside on the bench. You can rotate it on any side, and you can do the laser lithotripsy or maybe the pneumatic lithotripsy. We prefer pneumatic, not to injure the graft at all, because you don't know what the cold solution is there. There was some fluid is there, and you can take out such type of stones also on bench before we do the transplantation. Thank you very much for your patience listening.
Thank you so much, Pranjal sir, for that excellent presentation. You have just shown that the outcomes are directly proportional to the experience that you have got. And I'm sure Professor Anand Kumar will be commenting on it after we finish the next presentation. We go straight away to Professor Anish Srivastav. He will be talking something about risk reduction strategies in laparoscopic donor nephrectomy. Professor Anish. You have to go to the share screen, sir.
Dr. Pranjal has to stop sharing.
I'll stop sharing.
He has stopped sharing already. Sir, have you opened the presentation, sir? Anish, sir?
He has to unmute, actually. I think he's muted.
He has to unmute, actually. Anish, sir, can you unmute yourself?
He has to open his presentation first.
Have you opened your presentation, sir?
अरे यार वो बेग गड़बड़ हो रहा है इसमें ना, मेरे को आवाज भी नहीं आ रही है।
नहीं, आप अनम्यूट तो करिए। अनम्यूट कर लिया?
कर लिया, ये भी कर लिया।
अच्छा, ठीक है। आपका प्रेजेंटेशन कहाँ है?
उस पे डेस्कटॉप पे ना, मैं खोलता हूँ तो ये सब आ रहा है डेस्कटॉप पे। ये
हाँ, ये इसको मिनिमाइज कर दीजिए। इसको मिनिमाइज कर दीजिए।
स्टॉप शेयरिंग करो, फिर आपका प्रेजेंटेशन ओपन करो और फिर स्टार्ट शेयरिंग।
तक नहीं आ रहा था अभी एकदम से।
बहुत सारी फाइलें खुली हैं।
नहीं, मैंने यार इनको अभी सब ठीक चल रहा था, अभी गड़बड़ हो गया। अब इसमें मैं कहाँ से करूँ इसको? एस्केप करके भी नहीं हो रहा है।
Sir, in the meantime, can we have the comments from Professor Anand Kumar? And then we can come back to your presentation, sir.
कई सारी फाइल है क्या?
We can have the comments.
ये है ना complicated.
Yeah, sir, Professor Anand Kumar, can you just comment particularly on the stone related case that Dr. Oswal showed? There are a lot of comments regarding antegrade or retrograde approach, and of course on the presentation from Dr. Pranjal.
Yeah, that see, what is our strategy is, if we see any stones up to the less than 5 mm, we don't do anything, because we are 100% sure that once the diuresis occurs and we invariably put the stent, most of the stones, they disappear, and we follow them with the ultrasound. So up to 5 mm usually we don't do, and invariably they come out, because first thing, the kidney put upside down, and then the posterior calyx, wherever it is there, it just comes out. Any stone bigger than that, we take care of it. Like even today, there was a 1.3 centimeter stone in inferior calyx, and inferior calyceal neck was narrow. So like RIRS was not, so we did mini perk and remove this stone today. And up to a stone from 5 to 8-9 mm, we do the inch, like once the kidney is retrieved, we pass a flexible scope and put a basket and we take it out. And sometimes we have put the, like where it got stuck into the ureter, we remove from there. So maybe we use less shorter ureter, but that is fine. We can manage it. But we, like what Pranjal was saying, we avoided doing any lithotripsy inside the kidney, which is sitting in the table, because you never know what injury will happen, and and it may start bleeding later on when we will perfuse. We have done many patient RIRS before that, like there is a stone, you do RIRS, larger stones, and then do the transplant 1 month later, like retrieve the kidney. And we have seen whenever we retrieve the kidney, still there is a lot of adhesions and around the kidney. So there is some extravasation of urine, and these kidney, they have adhesions. So that's how we are managing. Larger stones, like today, we take care of it before, make the patient stone free. Up to 5 to 8-9 mm, we will take out by scope when the kidney is retrieved, and up 4-5 mm, 3 mm, we leave it, and most of the time they will pass. And second comment is, if you patient develop anuria, so the best approach we have seen is invariably there is some dilatation, and you make a superior calyceal puncture and then do antegrade removal, which is better, easier and faster, and then put a stent and come out. So these are the comments about the stones. And that the Pranjal, I was just wondering, because the first case which you have shown, there is a very...
I was not getting even their sound also.
Okay, so the first case of Pranjal, where you have seen that inferior polar artery was cut and there was thrombus. So most probably that artery was either dithermized or something and then cut or something. I don't know. Probably that may be the reason. But it was an acute event. So one thing I would have done, I would have removed that thrombus and flushed and seen. If the kidney is nicely flushed and the return was good and kidney looks good as like upper pole, I would have used it. If that was not looking, I will discard it as you have done it. Rest of the things what you said is very, very right. And like that renal vein thrombus one, I also won't use it, because you never know what is the extent of thrombus inside. But the acute arterial thrombus, once you remove it, most of the time acute arterial thrombus is you could remove the thrombus and perfuse the kidney, and you could have seen whether it is being perfused or not. And so that would have been, I would have tried and seen it. And rest what you did was very good, and that's what I would have also done it.
Yes, sir. Thank you so much for the comments, sir. They were really invaluable comments, particularly the amount of interest that was generated in the chat box regarding the antegrade or retrograde approach. Thank you, Professor Anand Kumar, for those comments. We go straight to our next session, in which Dr. Vikas Jain, Dr. Arjun Reddy, and Professor M.S. Ansari would be talking something on pediatric urology-related complications. I would request all the speakers to please restrict to the time. We are already running approximately 25 minutes late. Vikas, can you come in with your presentation?
Yes, sir. Sure, sure. Is it seen, sir?
Yes, it is seen very well. It's very clear.
Thank you, USI, ISU, and Ganpule, sir, for giving me this opportunity. Good evening to everyone. So I'll be presenting a case wherein I accidentally injured the lower polar artery while doing a laparoscopic pyeloplasty. I did it because I was not aware of its presence. So you have to know it to prevent it. That is what I'm going to present. So aberrant accessory or early branching lower pole vessel is one of the commonest cause of extrinsic PUJ. These vessels usually pass anterior to the PUJ or proximal ureter and could contribute to the mechanical obstruction. The incidences in various studies have been from 11% to 87%.
Okay, I think we can try
Vessels
to.
might affect the renal blood supply, so they are usually preserved while doing Anderson-Hines dismember pyeloplasty, which is the standard of care. So what are the investigations which we can do to find out the presence of a lower polar accessory vessels? The two major investigations are Doppler and CT angiography. Doppler is non-invasive, but the sensitivity is extremely poor, almost 40%. And pre-op CT angiography gives you the 100% idea that there is a lower pole vessel, but it's not usually done in most of the cases. And I feel it's an overkill. So it is not justified to subject all the cases to preoperative CT angiography just to find out whether there is a lower pole vessel or present. So what you can do to prevent these to prevent injury to this vessel is to take an extra precaution. So this is a young male. The video planned for left peritoneal laparoscopic pyeloplasty. What you can see is that this is pelvis PUJ, which has been dissected. And what I'm trying to do, the act is I'm trying to clear the tissue over the renal pelvis to create space for the tension-free anastomosis. So this is where I am removing some tissue over the pelvis so that I can get enough pelvis. I'm very cautious in my steps. I'm not doing it haphazardly and touching the tissues and everything. And so this is here I go. Yes. So I accidentally injured the lower polar artery. I was not aware of the presence of it. I thought it's just a adhesive tissue over there. So my right hand goes and control the proximal aspect of it. And I put in another port, which is a small port in the iliac fossa on the left side, from where one Maryland forceps is passed to have a proximal control so that both my hands are free so that I can do something about this vessel. The basic idea was to preserve this vessel. So that is what it is. It is held by one of my assistant who nicely holds it. Now he gives me some space so that I can think of how I can do, how can I go about it. So what I thought I'll go and suture this. So from my left hand, I myself take the proximal control. You can easily see the hole in the artery. It's very clearly seen. And what I do is start suturing this artery using 5-0 proline. After taking 2 sutures, I slowly release the proximal control. But still the bleeding is still there. So that means it requires 1 more suture. And that's what I did. I put 1 more suture. And after removing this suture, now there is no more bleeding. So I place a Hemlock clip just to keep the suture in place. So this is how it was done. At the end of it, I completely did the laparoscopic pyeloplasty without any issues after this complication. So this is a 3-month follow-up. The patient has, it's been now 3 years that the patient has been doing fine, and DTPS scan shows good improvement in the renal function. Here, now, if I want to ask a question, how can this be avoided? Yes, this could have been avoided. You have to know it to prevent it. The eyes are useless when the mind is blind. So after that, what I have made sure in all the pyeloplasties after this, I always think that there is a crossing vessel at the lower pole, even if it is not there. And I take an extra precaution while dissecting the tissues over the pelvis. And I stopped using the sharp instrument in that area. I try to do whatever dissection possible by not by the sharp instrument. Still, the vascular mishaps can still happen during the laparoscopic procedures, and the incidence is around 1 to 2%. Key to successful management in laparoscopic mishaps is do not panic, have belief in yourself, inform the other team members that something like this had happened. This was a injury to a smaller artery. If this would have happened to a major artery or something like that, you have to inform other team members that something like this has happened, and they should be very careful. Keep a close watch on vitals. Rescue stitch, that's what I have learned from Ganpule sir. It should always be there whenever you are operating any laparoscopic procedure. And call for expert help. It is extremely important if you are working in a team, because once it starts bleeding and you have a complication, sometimes it's very difficult to, you get lost. And somebody of your expertise and one of your colleagues operating somewhere in the other OT, you can definitely call for immediate help. Patient safety is first, and I feel early open conversion for any such complication you think you cannot manage is not the end of the road. I think it is early open. I actually, in the best interest of the patient, is much better than actually losing the patient or making some harm to the patient by continuing the laparoscopic approach. That's what I want to say. Thank you so much. I'm through, sir.
Thank you very much, Vikas. You really require nerve or steel to manage such complications laparoscopy. Congratulations for managing that case. We'll go into further discussion after we finish all the 3 cases, but thank you so much for the excellent presentation. We go to our next presenter, Professor Mallikarjun Reddy. He will be presenting on the title is very interesting, King to Monty, the eternal dilemma to redo or not. Professor Mallikarjun Reddy.
Good evening, everyone. Thank you, Arvind. Thank you, USI, ISU, for this. So this was a young boy who had been operated for, what was done was a continent catheterizable stoma with augmentation cystoplasty with MACE. He was a 13-year-old boy who was operated for a lumbar myelomeningocele at 6 months of age. Recurrent pyelonephritis subsequently. He had loin pain on and off. And then this boy actually had recently gained weight. His anterior abdominal wall the fat was about 1.5 inch thick. So his this was the MCU, and he had a small bladder, hyperreflexic bladder, and an open bladder neck. So what we did was we did an augmentation with MACE for his incontinence. And then along with that, we had to use a Monty. Even the MACE, we had a problem in terms of that we had to split the appendix and then put it back to the. So we did a double Monty in this case because we needed a very long segment to come out through the skin. So this was the one limb of the Monty which is being done after the augment. And every time when we do the Monty, we just make the first and the last stitch so that we can actually keep it straight and then put the catheter in. And now you see that you have a long limb which can actually go right into the augment so that it doesn't leak. Now we needed that extra again on the other side to come out of the skin. So this was a double Monty. And once the double Monty is fixed, we always make sure that this catheter is always pushed twice, thrice, 4 times, multiple times, and mostly done by the assistants, because once they can do it comfortably, we always feel that the things are okay. So this was a double Monty which was created, and this is the catheter which is going comfortably. So ultimately the Monty was fixed and it was brought out. As a standard, we actually keep the catheter for 3 weeks. And once we after 3 weeks, we remove the catheter, leave the SPC in situ and ask him to do the CIC through the Monty. He was advised to do the CIC. 5 days later, he comes. Generally, our technique is to hold on for 1 week or 10 days and then subsequently remove the SPC. 4 days, the boy comes back saying that he's not able to catheterize himself to the Monty. We had actually tried to do a dye study and nothing was going except that we could just see an initial small about 1.5 centimeter segment from the skin. Now then what was the option for us was that to see what's happening. So you can actually see that there is a significant false passage here. This is the false passage. And we could slowly get a guide wire across. Now, why did this happen? Then we went back and then looked at what happened. Post-surgery, the boy actually lost about 8 kgs of weight. And then the Monty became a little longer, though in spite we had fixed everything. So once this guide wire were placed, then we thought, what should we be doing? What will happen? We didn't want to push the scope because it's around 4 weeks. If we push the scope, we may spoil the dextroraphy, which can actually cause a significant leak through the Monty. And that is again a problem. And the boy would be incontinent from the abdomen, and that would be a difficult thing. So you continue to see that we were very keen that we don't go through the Monty into the bladder, and this was the false passage. And we also had actually hitched the bladder neck because his bladder neck was open. The reason because we have hitched the bladder neck, we are able to actually go across with a cystoscope. If we would have transected the bladder neck and have closed the bladder neck, we would not have accessed any of this, and it would have been a hell in retrieving this Monty. So once the guide wire was placed, again we had an issue that we could not put anything across. So through the guide wire, we actually cut a feeding tube. We cut the feeding tube and passed it across so that we straightened the track. So this is a feeding tube which came through, is coming into the urethra, and then we could retrieve the guide wire out. So we had 2 ends of the guide wire both held on each side, which actually made the guide wire straight so that the catheter would not kink. And then once everything was straight, we actually placed the catheter back in. Now the question was, will it work? We were hopeful that it would probably work because the Monty was quite okay. It was not leaking. The bladder end of the Monty was good. It was only in the middle that we had a false passage. So, and anyway, he has to catheterize every 3 to 4 hours. So that would probably take care of the stricture. So we actually put back the catheter. We exchanged the SPC and sent him back for the next 2 weeks. But then other thing what we realized was when he was taught the CIC by one of our residents, the second year told the first year, and then he told him to do the Monty catheterization with a Melton's catheter, and that actually caused it. Most of the time when we do a Monty catheterization, we want it to be done by Foley because it is soft and it does not create any of these kinds of passages. So this Foley was placed across the Monty. A 12 Foley was placed. So we could retrieve this at this point of time. It might not look a very devastating part, or it would look that it was very easy to do it. But any stenosis of the catheterizable stomas are major disasters, and there are about 25% to 30% stenosis of the Mitrophanoffs, and we had ended up in losing the Mitrophanoff when we were trying to actually get to the opening, and then we ended up putting an SPC and then going in and redoing a Monty or anything. It was a major surgical exercises. So these are dreaded complications because already these children are having a problem which had a major surgeries, and redoing a major surgery is and now the boy is now able to do we also should not give
Sir, you have to mute the computer voice. Yes, sir. It is fine.
No, it's over. Arvind, it is over. It's a matter of so once the boy was able to catheterize, now it is now it is 1 year that we are able to comfortably. And then he continues to be under significant follow-up. He has got about 530 ml of water for his mace. So he's continent both fecally and urinary also. Thank you, Arvind. Thank you very much for the.
Thank you very much, sir. Actually, I must congratulate you for that excellent documentation. Everything is documented so nicely. We'll take comments from Dr. Takwani after we finish the presentation from Dr. Ansari. Professor Ansari, can you come forward and present your case? You can unmute yourself.
Audible?
You're audible.
Yes, sir.
You can make it full screen.
Yes,
Full screen.
I'm going. Yes, sir. So,
perfect.
Good evening, everybody, and thank you, USI and Dr. Arvind, especially. And since afternoon, you all have seen the various kinds of complications, overt and covert. And sometimes the complication may be so subtle that it goes imperceptible, but halts the progress of any surgery. Herein we describe our ordeal when we lost pneumoperitoneum while doing a reimplantation surgery. So just giving a brief background and surgical steps where we started it. So this was a 4-year-old male child who had grade 3 VUR with recurrent UTIs and underwent transvesicoscopic ureteric reimplantation. The procedure started with the standard steps with typically circumscribing incision around the ureter. The ureter was being cleared from its parietal attachment all around, that is inferior, superior, lateral, and medial. All these dissections are done outside the ureteral adventitia. We gradually clear the length of the ureter so that it can be easily taken across the opposite side as to get optimum length and to maintain a certain ratio, length, and the tunnel. And this is, we are taking the flimsy attachment all around the ureter, just strictly staying outside the ureteral adventitia. And this is the inferior dissection. Usually the inferior dissection is quite easy. And this is the most difficult part when you dissect superiorly or cranially, because this is the most stuck part, maybe because of the Waldear layer. But just a minute. So, yes. So when we were working here at the superior part, this is the part which usually is stuck here. Once we cleared the cranial part, we suddenly started feeling this exaggerated transmission of the respiratory movement. Here. Can you see here? So we still somehow thought what is happening inside. And just after this, these respiratory movements basically got changed into the bladder-based excursion, severe. All the instruments were withdrawn here. We observed the patient. And this was the vision after that. We lost the vision. We took out the laparoscope. In the meantime, dipped in the warm water, cleaned it several times with the gauze piece. We re-entered. Again, the problem was same. We checked that the pneumoflow was okay. We also checked these points. The CO2 supply was intact. There was no any port displacement. Since we were using 5mm ports and we were using adapters 5 to 3, they were also intact. So can the expert comment on this? What actually went? We checked everything. There was a CO2 was flowing in, ports were properly placed, and the adapters were intact. Here.
Yeah, so Professor Ansari, that's a very pertinent question you have put forth. I will just put forth what I feel before I open up the question to Professor Anand Kumar. I personally, and of course,
my comments.
Sir, we'll first go to Dr. Ansari's comments. If you want to do, you can give the comments on Professor Ansari, and then we'll come back. That can be done in
I will just wait here to make it more interactive. What actually went wrong? We tried everything, but even then we were not able to see anything inside the bladder.
Dr. Ansari, what I feel is that in a couple of cases which I have assisted late Atul Thackeray, as well as going through the literature, probably it is not complication, but probably it is a limitation of vasecoscopic reimplantation. Because if you put the port little down, you are clashing with the ports as well as you are directly on the ureteric orifice. If you put little cephalate, you are likely to go through the peritoneum. So gradually the CO2 will leak, and that will lead to the collapse of the bladder. That's what I think. And that is a limitation, and that is reported very well into the literature.
Okay. So we, after trying everything, then we examined the child. Because the anesthetist has raised alarm saying there is slight rise in the EtCO2. When we examined the patient, we found there's a well-developed pneumoperitoneum. So we stopped for a while. Since the anesthetist was also complaining rise in EtCO2, and there was a well-blown distended abdomen also. So we went back, we rewound everything and see and check what actually went wrong. So here, I left you earlier with this clip. We were working here cranially. So what has happened? So when we were doing cranial dissection, so we had done a small hole in the peritoneum. Can you see? And that was leading to the CO2 leak into the peritoneum, leading to pneumoperitoneum. That is why we could not maintain any pneumovasicum. So, expert opinion, any corrective measure to this?
Virus needle, transumbilical.
Transumbilical. So you are very close to it. But I thought, because I was so tired, transvesical reimplantation is very exhaustive. I thought, why not to convert it and go to the cafeteria and have some.
That was the best option.
Yes. So anybody want to say anything? Dr. Arvind, you want to say?
No, actually I agree with Dr. Takwani that if you want to continue it laparoscopically, then you can put in varus needle. Otherwise, the best option is convert into it open. Thank you so much, Professor Ansari, for that excellent presentation. Dr. Takwani, your last words on both the talks, on all the three talks.
Can I have my skin share quickly? I will not take. I will take only 6 minutes.
Okay.
Right.
Yes, you can go ahead, sir.
So this is about the Vikas case. Vikas, you did a fantastic job by repairing these crossing vessels. But what I feel is the Arvind is okay. I'm audible.
Yes, you are perfectly audible.
So we know this association is since last 2 centuries, and as he's mentioned, it is very much possible there in the small children, that is 11 to 15%, and it can be much more even in the older children or adolescent period. So it is very much important that we have to maintain high index of suspicions, and specifically in patients with the pain at presentation, nausea, vomiting, often influenced by the child's hydration status and the later age. are predictors of crossing renal vessels. And if you, for that reason, if you go for extra mile, Vikas, then there is nothing wrong into that. And this era is, suppose if you have a facility of MRI, we can have a MRI addition to the diuretic renal scan, and or you can even omit the diuretic renal scan, because MRI can give us a functional as well as anatomical detail if MRU. And if it is not available, then we can go ahead with the limited CT IU, where you can see this crossing vessel, or you can see notch and the UPJ. And the operative pictures are very much in the our West Zone pyeloplasty webinar couple of days before. Dr. Mallikarjun, our president-elect, demonstrated very nicely that generally when you pick up the ureter, thereafter you trace the ureter and see for the thick band in almost all patients. If the thick band is seen, then try to visualize the pulsation. If not, appreciate the pulsation by palpation. And once you confirm it, it is better to go above at the UPJO and then dissect pulling the UPJO underneath the crossing vessels, and then you can cut it and transpose in front of the vessels. So Vikas, do you want to have a last comment?
So that's what actually you have to know it to prevent it, and by whatever investigations you can know it, you can definitely prevent it.
See, the thing is that if you have something very sure that you are heading for the crossing vessels, you will be extra aware. And in that case, in your case also, you would have been avoided this complication. Now, yeah.
Thank you, sir.
So next is the Monty. This is for the PGs, those who have joined this. This is the principle of Monty, that almost 5 to 7.5 centimeter of the ileum is selected, and then it can be divided in equal portions, and then it is opened up and sutured to make a tube. If you require, suppose each segment generally gives a 6 centimeter of the tube. So if you are in need of 6, you can take 1. If you are in need of 12 or 10 to 12, you have to take a 2. That is 5 centimeter. And if you are in need of more, you have to take a 7.5 centimeter of the ileum. It is a versatile procedure, and Dr. Mallikarjun demonstrated a very innovative concept of using Monty for this Mitrophenol purpose. And to my mind, the problem is that whatever tubing you do, but there is some petulousness is always there into the lumen, and that can lead to the problem with the passing of the clean intermittent catheter, and that can lead to the false passage formation. Otherwise, it is a very versatile. And the kinking is very much known. And I think, Mallikarjun, you would like to have a final comment?
Yeah, only one issue which we always don't do a very large Monty. When we do a Monty, we make it snugly fitting to 14 catheters so that we can do a 14 or a 12 catheterization subsequently. Right. So we don't want to do a large Monties in this.
I have only experience with the Monty that is of ureteric replacement in a very much traumatized ureter or a longer.
Augments get a Monty, and we are very happy of their long-term patency. We do get some issues in between. This was something which, but a lot of our children are happy because you can have a big catheter. They empty the bladder very quick. Otherwise, through a Mitrophenol, you have to put a 10 French infant feeding tube. It takes a long time to drain the bladder. So, and the opening of the Monty, the
Malika, very much appreciating. But the last question, as I promised Arvind, I have to finish in 6 minutes. Last question is that, is there any reported series about the use of Monty as a Mitrophenol?
Yes, it is actually our own publication from Belgaum, from me and Dr. Nelly, that we have actually published the Monty versus Mitrophenol patency rates.
Perfect. So I really congratulate you. It is really, really very innovative. And maybe your patient was unfortunate or unlucky in that way, but otherwise,
no, he's fine. So we are very happy with the boy at this point.
Right, perfect. And this is last, my dear friend Ansari sir. As I told you, that vesicoscopy procedure itself is cumbersome. The people like you and probably Rama Jayanti and many others took it, and almost they also decide to stop it. So I would like to know your final comment.
Would so yeah, the final comment is in this picture. Yes. Yes. Final comment is in this picture. So we did not use the Veris needle a vein flown usually or this is usually available in most of the operation theater. Those who are using Hassan's technique or open technique may not be getting a varus needle. So this is a simple solution for this problem. So if you are doing a retro, by chance you develop pneumoperitoneum, then you may put anteriorly a simple this IV cannula or 16, 7 or 20, whatever is available can solve your problem.
So, sir, I think that this is not the complication. These are the limitations of vasecoscopic procedure, because it's a small bladder and you have to put 3 trocars. And if you go a little up, your chances of going through the peritoneum is high. And also the fixation of the bladder is very much important. Otherwise, there is also possibility of port slippage as well as the leak. And what you saw, peritoneal rent and the leaking, probably I have not read into the literature. So worth reporting that this is one of the limitation there, because we always need to reflect the peritoneum from that part of the ureter. So thank you
so much,
Arvind, for this opportunity, and thanks to the Council of USI. Thank you very much.
Thank you very much, Dr. Takwani, for making it so interactive in such a small allotted time and giving your wise words of wisdom. We go straight away to our next set of talks, and we'll take Professor Anish Srivastav's talk after endourology thing gets over. So I start the endourology session by inviting Dr. Chandramohan Vadi to present his complication case. So Dr. Chandramohan.
Yes, sir. Stop sharing the screen, sir.
Professor Ansari, can you stop sharing?
Yes, sir. Done, sir.
Yes. Okay.
So, I thank the USA and ISU for giving me this opportunity, particularly Dr. Arvind Ganpule, sir, and Dr. Madhusudan Agarwal, sir. My talk is long segment ureteric stricture following laser lithotripsy. Honestly speaking, no conflict of the interest. Here, which laser is used is not a matter. How happened, why happened, how prevent, that was I'm supposed to talk. 37-year male patient, right loin pain 3 months, 2.5 centimeter, right lower ureteric calculus. When you see a large calculus, we always get in mind, open surgery or laparoscopic surgery or URSL. But being endourologist, we always get tempted to do endoscopically. Normally, we use pneumatic lithotripter, but I used thulium laser here. Because the ureteroscope is used, outflow will not be there like in access sheath. I repeat, outflow will not be there like in access sheath. So I used dusting and fragmentation repeatedly. Unfortunately, stone was moving up and down. I was chasing it. It took really time. 55 minutes in the ureter means quite long time. Generally, we do 15 to 20 minutes. Upper part fragments were there and relook was also done. This is the video how it is done. In this video, when we go inside, it was my mind was that to push back PCNL, but it is so much lower end, and in CT it is not able to go up in the initial part. See, it is like this impacted. Only up to sacroiliac joint it went. Then I started breaking with the laser. I thought I will nicely paint and finish without any fragments so that I can give one-time procedure to the patient. But in between, I was taking out the fragments. Lower ureteric orifice was good. Like this, it continued continuous uses of the laser because the vision was very good. I was opening the outflow in between, but this continued. There is nothing in this video to see, only except that laser is used even for pieces at different frequencies and energies. So this is the video. At the end, I stented. After that, as usual, after 12 days, I have removed the stent, and the patient presented with fever and pain. So when I went inside, this is the picture. It is a horrifying picture showing that intermittent inflamed flakes were there, which is a bad sign for any urologist. In the lumen of the ureter, I have never seen before like this. So I was worried. All the wall was looking like this, inflamed necrotic material like in matrix stone, particularly adherent to the ureteric wall, which is a very bad sign. So I thought whether to stent or PCN. Ultimately, I stented, but fever did not come down. These pieces did not come down. So I realized that only PCN will do the job. After the PCN, patient improved significantly because there was no problem. Then RGP and nephrostogram pictures are like this. This is the nephrostogram picture. Intermittently it is blocked. PUJ is blocked. That is the main problem. And below the ureter is multiple level segmented block. So I realized that it is a panureteral stricture. I cannot use any part of the ureter for any reconstruction because UVJ was narrow. Lower part, middle part, upper part, spindle dilatations are there. There is no point reconstructing with primary native ureter. So this is an nephrostogram with stent in situ. I tried stent many days. So why it happened is large burden impacted stone, high power laser with high wattage, laser used for long duration, no inflow and outflow of irrigation fluid, rise of temperature, thermal injury to ureter, and long segment stricture. So this is my repair. Even though I am not supposed to talk about how it is repaired, I want to, while going this video, I asked seniors what to do. They said that instead of going for iliac ureter directly, you raise the Boyari flap, whatever the length you take from Boyari, and the rest of the things you do with ilium. So I raised the Boyari flap. It was coming easily to the psoas, and the distance between so much distended bladders, fortunately in male patients, such a large bladder, around 10 centimeter flap was easily coming. So I made a large based Boyari flap. At the tip, I cut with the scissor like this, and easily it came up to the upper end of the kidney. Then with a lot of traction, this is only 1 minute video. I am finishing within 7 minutes. After that, there's nothing. Over the traction I did so that I don't lose the bladder. I have taken a stay stitch with the lower poral part of the kidney. Then I put a large feeding tube and then continued suturing so that it will have wide lumen. Once the upper part is there, I stopped suturing. Then I cut the ureter with nephroscope. I have seen where it is. First, initially this part was there. Then like in pyeloplasty, oblique cut was given. On the floor, interrupted 4 buttress stitches were taken on the floor, which is most important. Every time the bleeding was there at the edges, so I was happy. And the movement of the flap is very good. At the end, I checked that it is freely touching the anterior abdominal wall with pneumoperitoneum. Then I realized it is okay. A little bit of the momentum I kept around before putting the colon back. Patient is now post-op 1 year. He is doing well. So to convey that ureteric stone, you can use laser, but outflow should be checked. Long term should not be used. Whatever may be the laser, it produces heat. So we might have avoided by doing simple open surgery or laparoscopic surgery or pneumatic lithotripter or use of access sheath or worst scenario pushback PCNL. None has been done. That's why major suffering has come to the patient. Thank you.
Thank you so much, Dr. Chandramohan, for sticking to the time. And what I liked most was the way you analyzed what went wrong. Congratulations on a great presentation. We go
Thank
to
you, sir.
our talk by Dr. Harpreet Singh. He narrates us the tale of 2 forgotten digestants. Dr. Harpreet, you can unmute yourself.
Thank you, Arvind.
Yes, Harpreet, it's seen. Your screen
Can you
is
see?
seen very
Can
well.
you see my screen?
Yes, you can make it
Yeah.
full screen.
Yeah.
Yes.
Thanks, USI, ISU, especially Dr. Rajiv, Dr. Anand Kumar, and dear Arvind for giving me this opportunity. So I'll be presenting 2 cases. One is my own complication, and second I manage. So I just want to share something with you all. So this is a regular 63-year-old male, hypertensive. He has a mid-ureteric stone on the right side and left pelvic stone since 2015. So you can see a right mid-ureteric stone and left pelvic stone. Nothing much there except hydronephrosis. So he underwent right ureteric stone, which was uneventful, and he came for digestant removal after 1 month. So you see, he got operated in 2017. So then he again presented in 2018. So we did this pelvic stone, which was upper cholesterol puncture and a normal 18 French tract and 20 French ampules. So everything went uneventful, and he didn't turn up for stent removal. So he walked in after 2 years for digestant removal. So his labs were normal, and we did a X-ray QUB only, which shows a good stent. There's no obvious incrustation stent. So we planned cystoscopy and DJ stent removal under GA. So I was trying to pull the stent by cystoscopy, but I was not able to getting the stent. So then I put a ureteroscope along the stent to see whether if there are incrustations, but there were none. So I thought that there was some fragment. So I did a puncture in the kidney and went inside from the upper pole. And you can see that the stent is submerged or buried in the submucosa. So that's why it is not coming. Because see, there's no incrustations at all at any point of time. And see, a part of the loop of the DJ stent is buried in the submucosa. So I took a bug bee and I was keeping myself over the stent and slowly trying to burn the mucosa and submucosa to free the stent. Actually, I had not expected this. Is totally unplanned thing. Generally, you see a lot of incrustations with the stent. I was looking for in the literature if I can see any such reports where the stent got buried in the submucosa. I didn't get one, but slowly I was trying to say as much as superficial and close to the stent. This is done very recently during the lockdown. I was fearing also that it's pushed. It's just the debris which you're trying to collect. We're removing the stent. So this is the bird's eye view of the thing which we have created. So there was no other stone fragments. So this is the place, and there is no extravasation. We did the contrast, and you can see that this is the depigmentation of the area where the stent was buried inside. So his urine was clear, his parameters was post-op normal. So I don't know how it happened. Maybe edema of mucosa due to stone, guide were gone submucosally. These have created some to show you that it might have gone submucosally, or because it was forgotten. Maybe if it come after 1 month, we would have removed it and we never noticed that. Though if we do blindly, though the flora is always there, but not under vision, so it may go submucosally. So these are some of the things we discuss. I'm sure Madhu sir will put insight into it. So I always feel that you should do under vision and always keep on watching and don't try to force it. So I'll quickly go to my second case, who's a 34-year-old male. He's an insulin type 1 diabetes mellitus, hypertension, obese. He has gone left PCL and DJ stenting 4 years back. His labs were normal. So this is the position. He has got incrustation, stent was broken, and one was lying in the bladder, another, and it's full of incrustations. So IVP showed good function. So you can see the whole extent of the incrustated stent, which is lying inside the bladder, just fragmented. We passed the guide work before starting the fragmentation. We didn't want to lose it because of the edema. Sometimes it's difficult to see, as you know, half of the stent is inside the ureter. So as you know, the incrustation creates a lot of debris. So we removed inside the sheath without hurting the urethra, and then we went with ureteroscope along the side of the stent. Guide was pre-placed. So wherever the incrustations were actually occluding the lumen, we tried to fragment it so that the stent can be made free as much as proximally as possible. This video is clear, Arvind?
Yes, it is. It is very nice, very clear video.
Thank you. So we almost removed as much as possible to make the stent free, and now we did a lower collateral puncture. So checked around, we almost removed a few bit parts in the upper calyx also. In between, I just want to tell you that this guy developed allergy to the cephalosporin groups. So we were not able to give him higher antibiotics. We have to postpone once because as soon as he was given on OT table antibiotics got, so we posted him on another day. So we only went with Cifran and amikacin. So this is a puncture clear urine, and this is what we have. This is as a reconstructed picture. So, but post-op was very stormy. He got metabolic acidosis, urosepsis. He was on inotropes and ventilator for a day. As you know, he was type 1 diabetic mellitus, and we are not able to give him higher antibiotics. We have a stormy course, but he recovered from the second post-op day. And another thing happened in between. He developed allergic to contrast. So this is the non-contrast CT scan of the gentleman. So how did it happen? Patient has forgotten to remove it, consulted only when he becomes symptomatic. Surgeon may not have told him about the stent, or maybe economical factors. So what should be done to avoid it? Always show post-op access with DJ stent to the patient. Give him a date before discharge. Electronic reminders are some of the things which we can do. Thank you for your patient listening.
Thank you, Harpreet. Thank you very much for that excellent 2 cases. We go to the next talk by Dr. Rajesh Kukreja. He lets us know what to do when the tubes don't follow your direction. Rajesh. You have to unmute yourself. Unmute. You have to unmute, Rajesh. Rajesh, unmute. Unmute yourself, Rajesh.
Rajesh, you are not audible. Unmute your.
Making
or you have
post.
to call him.
I
Rajesh,
think
Rajesh, unmute. Rajesh, unmute yourself.
Sorry, he may not.
Yeah, we'll give it. Rajesh, unmute yourself. Rajesh.
He's not able
I think
to,
he's
sir.
having some difficulty. Can
you make him co-host, sir?
No, he is the co-host actually.
Can the host do it?
Rajesh, can you hear us?
Call.
Yeah, we have called him.
Unshare and share again.
Yes, now you are unmuted. Yes, now you are audible.
Sometimes you have to unshare.
Yes,
Yeah.
now you can share the screen.
Now am I audible, Arvind?
Yeah, you are audible. We can see also very well. You can go ahead.
Okay. So now I'll present with this very rare presentation which I had of when I've labeled it as when tubes don't follow your directions, when you imagine things to be very straightforward and they don't appear that way. So in retrospect, what happened before the patient came to me, this is the elderly 79, 80-year-old male, non-diabetic, normotensive, and just presented with flank pain and fever for last 2 weeks. The kidney showed mild hydronephrosis with perinephric collection and creatine normal. And so he went to a hospital and was managed by a urologist there. And it showed hydronephrosis, mild, and there was a huge collection. Now, if you concentrate on the left kidney here, where the arrow is showing, the large, just see the plate when it follows down. So almost the entire kidney is engulfed by a huge collection, and there are a lot of air pockets, as you can see in the collection around the kidney. And these are the axial cuts as you go from top to bottom, and then there would be a coronal thing. So that's the coronal section and cuts. And so these are the few images, and that's what was labeled a huge collection and within the Gerota's fascia and a lot of air. So query pyelonephritis or an infected collection. So what was done was a DJ stenting was done and a percutaneous pigtail drainage was done for the collection. And this was managed in the hospital there. Now, what happened after that is that for a week later, he continued to drain 1 liter every day from the pigtail drainage. The pigtail drainage would not subside, and he had a very good urine output urethral as well. They did a CT scan, and they reviewed the CT scan, and what the CT scan showed, the pigtail was there, and the collection was still present. It had regressed, but was still there, and they could see the stent also. They reported as the stent seen in the kidney, the upper end. So there you see, and that's a stent you can see there, and there's a stent going. There's a pigtail drain, but there's a collection still there. So with this, he came to us, and it was then 2 weeks after the stenting and drainage. The drain was having a liter every day. So I first thought maybe he's having some obstructive elements and it may be retrograde refluxing and coming out from some chalazial injury. So I put him on a perurethral catheter, gave him anticholinergics, and I told him wait for 5-7 days and let us review. The ultrasound was not showing any significant hydronephrosis, but there was a good amount of collection. He then again came back to me a week later, no change, still draining around a liter to 1200 ml. So then I did his creatine analysis of the fluid and the urine, and it was obviously what I suspected, that this was a urine leak which was occurring from somewhere. So I thought 3 weeks now is good enough time. Let me go in, I may change the stent, let me do a dye study from where is this leak occurring. So I took him in the OT, and this is, you see, this was the existing stent which was kept. And so what I did is I just removed the stent. And then I went in with my ureteroscope. I did a ureteroscopy with a plan to do a dye study and see. So this is a lower ureter, capacious dilated post stenting. And then I went into the upper ureter, and I just after that could not see anything. So I reached the upper ureter and I was not able to see any passage. You can see polyps, you can see some flimsy tissues. I have not done anything. I have not tried to put a wire, contrast, nothing right now. And the fluoroscopy shows this is at almost the L3 level. And then I did a dye study. And then you can see that the trickle going above, but it is all leaking. The contrast is completely leaking into the cavity where the pigtail was presumed to be kept. So then I further attempted, and then what I found this stone lying. This looked like a stone. So when I thought I reached the stone, I said I'm somewhere in the system probably. So I said I'll repeat a dye study again now at this level, with the scope there at the tip. And then I did a dye study, and I tried to put a wire, but the wire would not go. And then the dye study I said, and now you can see, if you see carefully, there is a streak of dye going into the pelvic calcial system, but majority of the dye is leaking into the perinephric area where the pigtail was supposed to drain. So I thought I'll use a flexible ureteroscope. Probably the curves would help me identify that tiny opening and would help me negotiate into the pelvic calcial system. So I tried. I came from the stone down. I could not do anything. I tried to put a wire, but the wire would now, then what was the best part? What happened is when I tried manipulating a lot, I could just see blind passages, nothing else. And now you see what I saw. This is the pigtail which has been kept. So now I was seeing the pigtail, and then I put a wire there. So the wire coiled into that perinephric probable cavity. I don't know whether you're able to appreciate the wire going down on the laterally. So I tried a lot, maybe for around 45-50 minutes we kept trying, but ultimately I bent the scope also, curved it. I could not get the passage. Then I said, let's, there was some dye which had already gone into the pelvic urethral system, which you can see the lower calyx in this picture. So then I thought, let us put a PCN and then keep it for a second day. So I punctured in the supine position, and because there was dye and the system was dilated, I used the ultrasound guide and I went in. So there you see the wire going down. And then this is of course edited video. I had to attempt many times. The wire would coil there, would not go. And then ultimately I was very fortunate. I could get the wire across into the ureter and the bladder. So I kept a nephrostomy, but then I thought, let me now again go from down, catch the wire and again follow it. So I kept the wire, and then I followed the ureteroscope on the wire from below and went there. And you see this was all shaggy, unhealthy ureter, which I could pass my scope. It was very, you see this ureter now? This it's completely destroyed. So now at that moment, I thought, let us put a DJ stent and let us come over the crisis. So over the wire, I put a ureteric catheter from below and took out the wire, then did a dye study, confirmed my ureteric is in the upper calyx, and then I just simply put a double J stent, making sure I uncoiled the flower of the Mallicot and made sure that the stent doesn't go through the Mallicot, this thing, and I put it, and a stent was then inserted. So after that, what we did was the drain immediately stopped post-operatively. There was good output from the PCN and the urethral catheter. 2 days later, what I did is then I clamped the PCN to see if the drain suddenly increases, but the drain remained nil, and then it was removed. 3 days later, then I removed the nephrostomy and sent the patient home with the Foley catheter so that it doesn't reflux, and then called him 5 days later, and then I removed the catheter and he was absolutely fine. So this was how we tided over the crisis at that time. Now, why did it occur? Because I had not seen it being occurring. So the thought which came to my mind that the pigtail, I had obviously seen the pigtail had traumatized the ureter. We could see it there. So we normally use a pigtail drainage very frequently, but probably it was not done under a proper fluoroscopy or a ultrasound guidance. And I always feel it is better if when you are, as a urologist, we are using a puncture needle and a wire always. So when you are very close to the kidney, lower pole, the whole thing is engulfing the kidney. It is better to puncture with a puncture needle, put a wire, and then put a Mallicot. So Mallicot drains better than a pigtail also. And pigtail you put direct. So whenever the pigtail goes direct, it may puncture anything which comes in the way. And that is probably what has occurred. Now, luckily, this patient just came to me last week after the lockdown, 4 months later. So Arvind had told me, so I got a CT scan done for him. All good, doing good, stent well in position, no collection absolutely at all. And I told, now let us do a ureteroscopic assessment, how the injury has taken care of itself. And he being 80 years and with all, now that not the right time to do too many aggressive things, I thought I'll just change the stent and put a silicone stent. That was my plan. So I went inside, I removed the stent, and then I went into the ureter. And now you see when I reached the upper ureter, but the wire went across absolutely, there was no problem at all. But now this is, you see the ureter. Now again, same level, I'm just removed the stent 2 minutes back and the wire has gone, and you see all this polypoid tissue and unhealthy ureter, probably a fibrotic ureter, a little bit of pushing. And because of my wire was there in the system, so I was a little bit confident, little bit of pushing, and I went into the upper pelvic urethral system across this bad area. And there I reached the kidney. You can see some infected stuff because the stent was 4 months old. And you can see some pus flakes also. Now I withdraw to show again. Now you see this system, this, there the upper ureter, that full almost inch of this inch or inch and a half. Now this is how it looks, completely damaged. Now there's no leak of contrast anywhere. It has healed, of course, in 4 months' time. But now this is the ureter. You see, that's a normal ureter. Now this is the bad ureter. And again, I come back into the normal ureter here. So then now I thought I'll put a silicone stent and give it time to heal, and then probably reassess maybe 6-8 months down the time. So now I kept a stent, he being 80-year-old, and I thought I'll just buy time, and I'll in fact take the opinion of the people here also and the experts as to what should be now done for this injury. Thank you, Arvind. Thank you.
Thank you so much, Rajesh. Excellent presentation, excellent documentation, and an excellent case. I would invite Professor Madhusudan Agarwal to give his comments on all the 3 cases. Agarwal, sir.
Well, friends, first of all, I must congratulate Arvind for bringing together such an excellent galaxy of speakers and cases, and altogether a wonderful program under one heading, under one roof. And since evening 5 o'clock, this has been a wonderful program and excellent presentations one after the other. Regarding these 3 presentations in the endourology section, all I can say is that in endourology, you have once again shown, all 3 of you, that each one of us in endourology is like one of, I mean, we are certainly among the best in the world, and every one of us is excellent. So the first case, what Dr. Chandramohan showed us, and he has mentioned this in past also, that when we start a new technology, we have to be very careful about evaluating it. And thermal damage to the ureter can be devastating. So when we start using lasers in the ureter, right, left, and center, we have to be careful about the risk of thermal damage to the mucosa. And I think he's highlighted these points very, very well. I don't need to repeat what he has already outlined, and he has analyzed everything very nicely. So I think I'll leave it at that. There has been a lot of debate between the question about thulium fiber versus holmium laser, and I think this will take a little while before we can finally determine which of these is better, or whether there is really additional thermal risk with the new thulium fiber laser. Maybe with experience, we'll learn how to handle this technology better, and we'll get better with that. Regarding the stents, which Dr. Harpreet showed, I think the most important thing is to have a stent registry, which all of us will need to follow, and make sure that every patient and the attendants need to be told about the stent, and they need to come back, because internationally, this is one of the most important reasons for litigation. But I was impressed, Harpreet, that you were able to take care of the stent infestation with pneumatic lithotripters. What we have found in our own experiences, that with the use of holmium laser, it is much easier. With pneumatics, used to be a much greater struggle. With laser, it's so much easier. But yes, as you have just shown, you can do it even with simple pneumatic. Regarding the third case, which Rajesh has shown, this is actually a masterpiece. The only thing I would say is that Rajesh, instead of struggling for so long, in your place, I would just put a percutaneous nephrostomy and called it a day, and maybe it would have come back after 2 weeks or so. But yes, what the points that you've highlighted are absolutely pertinent and excellent. And in the end, I would say that given the patient's age, a permanent ureteric stent is something like a Memocat or one of those permanent stents which Cook has. It may be a good idea. In India, because of the cost, maybe we don't use permanent ureteric stents so much. But if you see the Western literature, there is a lot of use of permanent ureteric stents for malignant as well as non-malignant strictures in such patients worldwide. So I think, thank you, everyone. I don't think I should take too much time because we are already running behind time.
Thank you.
But,
Thank you so much, sir.
thanks again for an excellent show, Arvind. And carry on, please. Thank you.
Thank you so much, sir, for being so articulate and precisely making all those comments. Thank you very much, sir. We go ahead with our further talk. We'll just squeeze in Professor Anish Srivastav's presentation, which we just lost in between. Sir, I would just like to request you to be on time, 8 minutes, please. Over to you, Professor Srivastav. You can unmute yourself, sir.
Yeah, Arvind, I'm trying to share.
Yes, sir. Share the screen, sir.
Yeah, I'm trying to share, but
so you go to the bottom of the screen and there is an green icon. You click on the icon, sir.
Green icon. Okay.
There will be again a share comes at the corner.
Then you'll get a box wherein you will see your presentation.
Yes, I'm starting a share screen, and then optimize screen is coming. So
yes, you optimize, tick on the icon.
Optimize for the video clip.
Then you click on the presentation, so it will be selected.
No, but it is actually the share thing again.
Yeah, share thing नीचे green वाले. नहीं वो प्रेजेंटेशन खोलिए ना.
प्रेजेंटेशन पीछे है ना, इस पर वो ये हटेगा ना तब तो. This has to. यहाँ से share कर.
Have you selected the presentation, sir? Is the presentation open?
It is open actually, but I have to go back to my desktop. So that is where.
No, Srivastav sir.
Yeah, just 1 minute. I think we can
share screen. और उसके बाद basic.
Yeah, now.
File खोलो. इसको full screen.
Now, can you see my presentation and here?
No, sir.
No.
We cannot see. Professor Ansari, can you just help Professor Srivastav?
He's here.
Yes.
Sir, then can we come back again? We'll go to the next presentation, and then again after the next session we'll come back, sir.
Just few more seconds. Otherwise, I don't know what is happening.
Which computer you are using, Mac or?
Mac.
Mac. See, you go to the system preference, and there is a small button, and just click it.
But every time it was happening today, I don't know why it is troubling.
Go to
anyway,
the preference and hit the box, and it will open up. Yeah.
Now, is it seen?
Full. Yeah, you make it full screen. Sir.
Okay, fine.
Always believe you are president.
Right.
Yes.
Sorry about it, and I'll be very, very brief. And so we all know about the various complications in laparoscopy as such. So I'll be talking about few points which are very specific to the donor nephrectomy. So this is from the Cochrane database, and more than Clevian 2, the complications are less. We also published the same, and but the fact is that there are complications. So before we start we go to the operating table, one must have a very good look, not only at the coronal sections, but also at the transverse section. Especially on the right side, the lower polar artery can be anterior, and the accidents have happened. They are they are reported that out of these 3 arteries, the inferior polar artery actually got injured because the radiologist also wished, the surgeons also did not see that this artery is actually in front of the IVC. Generally, they are behind the IVC on the right side. This one is on the front of the IVC. So a very good study is important. A small artery can go into spasm, and there are reports of burning it as because you think it is a more of a lymphatic thing. So retrocaval renal vein and double IVC, nothing should come to you as a surprise. Now, when we go to the donor nephrectomy, we already discussed about varus needle, and I strongly recommend, especially in the large teaching units or large corporate hospitals, where only 1% is not using varus needle. I think we should go for for a open or Hassan's technique, which is very safe. And so then I'll show you certain other very important points. Now, this is another database where it shows that there are issues with varus, and there are with open technique entry you will rarely fail, but you can fail entry like the first case. You can fail the entry with the varus needle. So recommendation is to use the open or technique. Now I am not showing you the video. We all know the steps of because this time is short. So steps are after entry, and then we go finally to the renal artery dissection, vein, and everything. So important thing is that when you are doing the upper pole, then you should not come close to the kidney, because sometimes the upper polar branch may get injured there. And similarly, if you find an adrenal which is very densely adherent, as is seen in this case, then don't try to try to remove, separate it, because there would be a capsular tear like this. Sometimes this can be bad, and so if you can't do it, then better to like surgeon is trying to do, and then you see the capsule is tearing. So you can take the adrenal along with the kidney. That is called a gifted adrenal. And on table you can see again very gently, but don't try to do that. A point about where we should divide the ureter. So we published this again because there is an incidence of orcalgia seen in many patients, or testicular pain. Donor as well, mostly the donors, because you tend to go down, in order to take a more and more length of ureter, which is actually not required. 2 centimeters below the lower pole is good enough. Therefore, you should always clip above the iliac vessel. The reason which we found from literature was that the hypogastric or the sympathetic supply in that area below the iliac vessels gets hampered if you or when you put clips in that area. So above the iliac vessel, and it will be okay. And then one has to, once you have cut the ureter, you have to check the urine output. And then systemic heparin and protamine reversal, or systemic heparin alone, has been used by some, but we have seen studies, we never use it, and it is not recommended. The idea is to prevent vascular thrombosis in the donor. So now you see this study from Dr. Gill and Dr. Behir, and 40 cases in each, some with heparin, some without. And then they said there was no higher incidence of vascular thrombosis. So heparin is not to be required. Now, coming to the major issue for this talk. So these are the various options. So option A is out in a donor, and option C also should not be taken out of B and D. Why should we do that? Why there is so much of concern in the donor? Because the same clips are FDA approved, everything fine in radical and simple nephrectomy, but why in donor? So this is because the philosophy is a donor surgeon always tries to gain more and more length. In the bargain, sometimes he may compromise, and which is not required. Even here, if you see, let the arteries become 2. We'll do a good bench dissection and then join them together, or whatever we can. All transplant surgeons can do multiple arteries well. But we should not be compromising here, thinking that, if I if I press, put a clip close to aorta, this and that, that should not happen. So do not compromise. And then I'll come to what is happening today. People are confused because our practice is 2 hemolocks and 1 titanium clip at the base. They say, why do you do it? There are some who are putting 2 hemolocks. There are others who do stapler. So in 2006, there were a couple of cases of donor death. And then FDA reviewed everything. They found all the 3, like the hemolock clip, the titanium clip, and the staplers. They all had issues. But then, and based on that, they actually looked into the mechanisms of failure, device failure and all. I'm not going into detail. And then they said that it gave a class 2 recall. Class 2 recall means that this device should be avoided. At the same time, that because it can cause harm. So this was the thing. And the company also said that in donor, you should not be using the hemolock clips. Then in 2008, 8 institutions took this study from Europe, and then they said these are the things which we should actually be very careful while doing this, and these are the things which one should take care before applying the hemolock clip. And I'll just here quickly show one video, or do you think I should go without video and present? You want to? I think this is important video. So I'll quickly show this. I have to close this so that we can come to the video. So this is the video which is showing how one should put the hemolocks safely. Okay, so good circumferential clearance all around the aorta and the artery where the clip has to be applied. Leave 4 millimeters of 3 to 4 millimeter from the origin of aorta. Look at the, before you apply the clip, I'll show you when this clip is being applied. Look at the hook of the clip. Can you see that? And see that the whole thing has come. The entire thing has come into the stem of the clip, and then apply another titanium clip. This is for the legal safety here, because only on, if you see, look at the textbooks and everywhere, they say only 2 hemolock clips are not enough. And after that, only leaving 2 millimeter cuff, you should cut the artery. So that is the very important thing, and that is the crux to this matter. Now I'll take the process. Okay, go back to the screen, or we can show another video. This video. So this is another video which I am showing, where we have all. We have put the clips on the vein, and now we are cutting the vein, right? We started cutting the vein, one cut given, another one given. There is one artery which we already did. There were 2 arteries, and then you give a 3rd cut, and this happens. So, so what has happened actually? Slide. So I'll go to the main presentation and full screen. So this is what happened. This is the full. Yeah. So this is where the injury occurred. So when you cut the vein, so important thing is after cutting the artery, when you cut the vein, keep the arterial stump also in view. Otherwise, inadvertently, there can be an issue. So now going back to the important point that whether this is the latest systematic review and meta-analysis here, which says that hemolocks are safe, but because the company does not allow you to put the hemolocks in donor, and because there was a FDA class 2 recall, we tend to put, Dr. Anant also does, and many others, we put another titanium clip. So we are not depending on the only 2 hemolocks. Actually, they are enough, but for medical legal purpose, we are putting another one also. So I think with that, probably I think I'll finish my talk. Thank you very much.
Thank you, sir, for that informative talk. We'll, in the interest of time, we go straight away to the next presentation. I hate to say this, but I would request the speakers to just stick to their time of 8 minutes because we are already running 38 minutes behind time. I invite our next speaker, Dr. Ajay Bhandarkar, to talk about bleeding and transurethral surgery. Can we share the presentation?
यहाँ से वो करना है क्या? No. Stop share or something.
Anish sir, you need to stop sharing. Yes, you can start, sir. Bhandarkar sir.
I'm not able to share the screen.
Just 1 minute. Just one. Stop. Stop sharing. No, I have done that. Can you start, Dr. Bhandarkar?
No,
Ajay sir, can you start?
No, I'm not able to see any.
Is it behind this?
No, we are not sharing.
Dr. Bhandarkar, you can start your talk. You're unable to share?
Yeah, I'm unable to share. While I press on that share screen, I get a blank this thing, white slide, basic, advanced, and files, something like that.
Okay, so can we do
my screen share for the video clip?
Bhandarkar sir, open your presentation first. First, open your presentation and then share screen. First, open your presentation.
I opened it. I kept it open, ready.
Now then go to share screen in Zoom.
Yeah. Can you see now?
Yes, we can see it. You can go ahead, sir.
Okay. So at the outset, I would like to thank the USI for giving me this opportunity. Anyway, we are running late. I am supposed to speak on transurethral surgery and bleeding complications. I think they are the most fear about. And we all know that the transurethral resection of the prostate is decades old. I mean, so many years we have been doing the prostate surgery. And we know that the literature says that in 60s and 70s, the blood transfusion requirement was more than 35 or 30 to 35%. Maybe in actuality, maybe more. But it drastically reduced in the late 90s to 4 to 12%. And one of the reasons is that we developed more expertise. There was good optics, good equipments, and the video, and the camera system and everything. We were able to analyze where things were going wrong. So the transfer rate, in fact, has dropped down to 4 to 12% in late 90s, and in some of the literature in 2015, which is published, maybe because of the bipolar and the lasers and everything, the overall transfusion requirement is around 3 to 3.6%. So bleeding complications, even though they are not, very common these days, but everybody still fears the bleeding complication. There are many factors responsible, but I'll not go into the details, but I'll just tell you the overall view that there may be a patient factor which is responsible, there will be a prostate factor responsible, And one of the most important, that is surgeon. Novice surgeon versus the experienced surgeon makes a huge difference. And I would like to comment here is that the technology and the technique also will make a huge difference as far as the bleeding complications are concerned. And the technique can take care of, the complication irrespective of the technology used. So it has to be a technique which is more important. So I'm just going to share a few examples like that. Here, this is a gentleman who had, I just would like to make sure that is the video seen nicely, Arvind? Can you see the video?
The video is running very nicely. You can proceed,
Okay.
sir.
So, this is the example of about 70, 80 gram prostate in a chronically, obstructed person who is on echospray and vascular and large glands. All of the factors are, more high risk for the bleeding complications during surgery and post-op surgery. So we have to be careful. So a good endourologist will anticipate a problem and then take care. So that is the most important factor in endourology, to avoid complication or prevent, be aware of what can go wrong. So irrespective of the, here I have done a bipolar enucleation, single lobe enucleation, and luckily, we could take care because I was aware about all these complications can occur. So you have to be, it is 100% sure that you have to have a good technique up your sleeve. So next video, I would like to show that same thing may not be true every time. So this is again an 80-90 gram prostate, which I was trying to enucleate with the bipolar button. And I'm just trying to work at the bladder neck. I'm trying to, Nesbitt technique and dropping the right lobe. And as you proceed further, suddenly you will see that there is a gush of blood seen somewhere, and then you don't know where from that blood comes. So suddenly this blood comes. So you have to be aware of all these things. And when it happens, don't panic, just relax. Look at the equipments you have, just empty the bladder and go back and try to see where from it has come. So you know that you are trying to drop the lobe from that side and one of the vessel has been compromised. So if you don't see on the same side, it could be from the opposite side, that is a ricocheted typical arterial bleed. And when you go to the opposite side quickly, and you will see that a smaller spurter is seen here. So this is how you recognize the arterial bleed, that on the same side of resection, if you don't spot, you just quickly go to the opposite side and then try to control the bleeding. Once it is controlled, I think the field improves and you can proceed with the procedure. So this is how the arterial bleed, sometimes if it is not seen on the same side, you just look around. So this is one of the trick which you have to see. But one of the most dangerous thing is a sinus bleed, venous sinus bleed. This is a case of about 135 gram prostate, which I enucleated with the holmium laser. But 35 gram prostate, my morcellator was not working. So I was trying to do a mushroom technique. And this is, how did this happen? Because you have already worked near the capsule, and by resecting, if you go still very close to the capsule, and some of the veins, the venous sinuses are very close to the capsule, and you can compromise that integrity of the capsule and the venous wall. And you see that with the irrigation pressure and the coagulation being done all around, you stop. But as soon as you stop the irrigation, the sinus bleed will continue. So in that case, what you do is that don't focus entirely on the venous sinus. You look for some other places that you are almost done with the procedure. You remove some of the pieces of the tissue. And once you remove the tissue piece, bladder gets empty, the sinus bleed worsens. So you have to be aware of all these tricks, all these things happening. So again, try to coagulate all around the vein, and then you know that this is a small venous sinus opening that can be taken care by the traction or a catheter. So what you do is that not only put your energy there, look for some other sources of the bleeding, somewhere near the bladder neck, small oozy also. And this is one of the arterial bleed or some on the opposite side. So you have to be aware that not only the sinus bleed, but small oozing, small arterial bleed, all should be taken care. And then you make sure that the fossa is nicely clean and clear, because sinus bleed may not, stop, but it will stop with the full bladder. So all these things you should know, and then try to avoid, finish your procedure as fast as possible. And then this is what's still happening, that you spend some time try to coagulate, but then you accept at certain level of procedure which is completed and then just put a catheter and give a traction. I think that helped. So in the whole beam laser inoculation of the prostate, which was not supposed to bleed too much, but with small mistake here and there, the patient ended up losing more than 100-150 ml of the blood, which is not clinically significant. But this is how these things happen. In the next video also, I would like to just highlight one more sinus bleed which happened during the bipolar resection. That here the gland was again big, very vascular, and on the left side, you see a gush of blood coming from the capsule area. So you know that you have compromised the sinus here again. So same strategy again. You try to coagulate all other bleeders other than that sinus bleed. There will be a lot of oozing in the vascular gland around the bladder neck. You take care of those blood vessels, and then you always make sure that you finish your resection, whatever rest of the tissue is there, so that in case you have to abandon the procedure, at least the small tags and everything is complete. So, but try to coagulate too much around the sinus, you may end up opening the vein too much. So you must know where to draw a line. That you cannot always stop this bleeding with a lot of coagulation. A lot of coagulation will damage the tissue around and will make the venous sinus worsen. So this is the message I would like to make sure that everybody gets. And you just, once you have done the rest of the things finished, you put a catheter and give a traction. I think all this venous bleed stop post-operatively. Sometimes for the roaming urologist, you will see that you are doing a TURP somewhere else, or you are having only one loop, and this is getting thinned out when you do a resection. And it's a small gland, but when you work with the loop 6th or 7th time or whatever time, you will see that here in this. So this all the things in the practicality may happen that you are doing and the loop breaks and there may not be a second loop available. So what I would like to say here is that you can, one of the active part of the loop, you can still, fulgurate or, vaporize and then take care of all the bleeding so that patient is not suffering at the end because of your technical little hitch. So this is what the small video which shows. So that is end of the video. And I would like to share only one slide here, that the pre-operative treatment with 5-alpha reductase enzyme inhibitors, and there is starting this for 4 weeks or 2 months or 6 months. There are several studies published, and one of these studies I am quoting here, which has shown that there is no significant association between the use of these drugs and lowering the risk of hemorrhaging events. So there is no uniformity in the scientific literature about the exact use. What is more important is the technique and how you handle. So in conclusion, I would like to say that the bleeding complications in transurethral surgery is one of the most important intra and perioperative concern for everyone, whether it is a senior consultant or a junior consultant, or straightforward surgery or a complicated surgery. With proper technique, knowledge, and the calmness, one can handle this situation. Thank you. Thank you very much.
Thank you very much, sir, for that nice presentation. Taking the story further, I would like to invite Dr. Rahul Gupta to talk something about post-URP rectal injury and post-URP urethral strictures. Rahul, can we get your presentation in? You can unmute yourself.
I'm unmuted, no?
Yes.
Thank you, USI, and thank you, Arvind, for inviting and giving me this opportunity. I hope you can see my slides properly.
Yes, you can make it full screen.
I have not made that. Yeah. So I'll just be talking about the complications, and I'm really thankful to you because we all feel that we are senior surgeons and we can't do complications in TURP. But when I went through the record and found there are quite a few, we have also done it. So my aim of this presentation is always follow the basic principle of TURP. Why? Because TURP to a urologist is like appendectomy to a surgeon. If you do a good TURP, then what? But if things go wrong, it's a great problem. So start always with the CPE. It was with me also that when you become senior patient as a catheter, just put a scope and you start resecting here and there. But I think you should give 2 minutes and do a good CPE, plan the procedure, and then go inside and go ahead. So the complications, I'll be discussing as what can happen, when it can it be avoided? If not, then what are the options for us? So the first case which I'm going to discuss is that these complications can happen either intraoperatively, peri or post-operative, as we all know. So this is the first case. Is a 75-year-old male with cardiac comorbidity on anticoagulants, which was stopped. He had a history of cystolithotomy open, which was followed by a TURP. Now he presented with passing of the fluid per rectum while trying to pass the urine. So when the patient came to us, now what to do? I thought I'll do a RGU in the patient and see where the leak is, or an NCUG combined and see what is happening to the patient. When we did that, there was a bulbomembranous junction stricture there. So should we do a cologram, colonoscopy, CCT with reconstruction, or an MRI, or a cystoscopy? So this is the chronology of events in which, if the patient gives you, a history of leak of the urine or fluid coming out through the rectum, so this should come in the mind that there is some connection is there with the bladder to the rectum. So this is the MCU, and when we did the MCU, there was a small stricture at the bulbomembranous junction. But I was not happy with this MCU, so what we have done is, we have done an oblique plate. And when you do an oblique plate, you can see a clear-cut extraposition of the contrast into the rectum. So CT MCU was done, and there is the fistula which could be demonstrated. So this is the cystoscopic finding which has been done. So if you look at, there's a tight narrowing there, and we're trying to look for this thing. A guide wire is passed, and the guide wire goes in and it comes out through the rectum. It's a very small fistula, and when we did a per rectal examination, we could feel the guide wire there itself. So why did this happen? Is it something to do with the stone surgery? I don't think so. TURP, where did things go wrong? I'm yet to see a fistula after a TURP, but this is a case is there done by one of my very senior colleagues. What's the rate of prostatorectal fistula after TURP? The literature says it's very rare. Is channel TURP more likely to cause a fistula? And are there any predisposing factors? We'll ask our experts at the end of the talk. And what about laser enucleation? Can a laser is safe, or can it or cannot it cause a fistula? So whatever the options in front of us, a conservative, surgical, after how long, open, or perineal approach. I would like to see what my panelists would say. Either a trans or a perineal approach, or a transvesical approach has been given in literature. Can we do a minimum invasive surgery, which can be laparoscopy, or Arvind will guide us whether we can do a robotic surgery in these patients and get away with it. So the treatment modality, it's a rare. This is just what I could get. What we did in this patient was, the basic principle of treating any rectoprostatic fistula is a 2-layer closure, suture to the urethra and the rectum. The suture lines should not be at the right angles, and interposition of the soft tissue is mandatory, either in the form of a omentum or a gracilis flap, muscle flap, or a scrotal or a tunica vaginalis. So this is one of the most commonly performed ways of doing it, is a York-Masson approach. And what was done in our case was a conservative treatment. We did dilate the urethral stricture, put up an SPC in the patient, and did a diverting colostomy with a low residual diet. And fortunately, the fistula did heal. This is a cologram which has been done. It's done after about 3 months of the conservative treatment. We can see the balloon of the catheter of the SPC here, and the cologram and an oblique plate. There is no fistula now. Fortunately, we could get away with this thing. Any questions, Arvind, now, or you want to take it at the end of it?
We'll take it at the end of the talk.
Okay, then this is the second case. He was a 60 years old male, BPH with obstructive LUTS. A TURP was done, catheter was removed, patient voided well. Then it comes back after 3 weeks and complains of a poor flow. So how to approach? It's a standard approach. We did a Uroflow. I was not happy with the Uroflow, and this is the RGU which was done. So options were discussed with the patient. He refused outrightly. He's on a dilatation. This is the recent, the RGU of a patient, a simple stricture at the, the anterior urethra. We all know the common sites of the urethral stricture, that is the BM junction or the submeatal or stenosis at fossa navicularis. But this patient had an anterior urethral stricture, and this is the, the CP finding of the. This is the ureteroscope. I'm using a ureteroscope to see for the fistula. Sorry, for the stricture. I thought we may do something definitive for this patient, and I would like to take the opinion of the experts what to do. The posteriorly, it was absolutely patulous and normal in a pink, and only a small narrowing at the short segment could be appreciated. And there we can see the prostatic fossa, which is nice in the URS. You can't see, but it's well resected fossa. There is no problem there at all. So it's all about the literature, why this can happen. So it can happen because of oversight resectoscope, a mechanical stress, mucosal damage, and a long catheterization time can lead to these fistulas. The urethral mucosal damage is due to the mechanical stress. We always have to remember, sometimes the surgeon becomes heroic. We see large prostate, 200 grams, 200 or 180 or 170 grams, and we want to do it endoscopically. But always remember that it can end up in a urethral stricture for the patient. I think we should be very cautious once we are doing and knowing what our experience is doing that thing. Role of cautery and lubricants is always there. Because of paucity of time, I may not be able to discuss everything. But yes, one point I want to just highlight here is that you should use a good lubricant, no compromise on that. And of the other factors, this is one of the very important studies I came through while I was reviewing why the patient can develop a stricture. And in this study, they have done a 6 months follow-up for a urethral structure, and they found that when you do the irrigation fluid, warm irrigation fluid in 36-degree temperature to the cold irrigation fluid in the places where there is cold, like hilly areas or the places where the TURP is done in the cold atmosphere, the level of a urethral stricture was much higher. It was less when you do it at a room temperature and a warm irrigating solution vis-a-vis a cold solution. And the reason they have given it that the cold irrigation solution may lead to constriction of blood vessels in the urethra with a high risk of urethral stricture formation. I don't know, but this was one of the studies which was very interesting, so I wanted to quote this. So the size of the scope is very important whenever we use. There is no doubt about it. And now the stores is there. We have a scope which is available, and the technology used. Again, a lot of we are seeing a shift, a pentagram shift from monopolar to a bipolar TURP, thinking that bipolar is much more better than a monopolar TURP. But if you see at the stricture rates, I was surprised to go through the literature, though many people say the stricture rates are same, but there are studies which say that the using of high cutting current that is going up to 270 watts versus the conventional monopolar TURP is 120, that leads to more incidence of stricture, and the literature is available there. And the treatment of choice is buccal mucosa, but provided the patient, agrees to you. This is one of the papers by Kulkarni sir, and it is a recent paper in World Journal of Urology 2019. So this is the best option for the patient. But if you look at the results, so it is 82.43%. So my take-home message would be, whenever possible, avoid a stricture. Be very wary of the things what you're doing. Look at the time and everything. Checklist before you do a TURP. I have one more case, but I don't know if you will permit, but this has been discussed. This was a subtrigonal perforation. I think Manor is going to discuss this.
I think Manor will be discussing.
Yeah, Manor will discuss this. So I'll not do it. So I'll just end up with the.
Thank you so much, Rahul. It was really an excellent presentation, and thank you for keeping to the time. Thank you so much. We go to Manor. Dr. Manor, can you share your presentation?
Yeah, thanks, Arvind, and thanks for the USI for giving me the opportunity. I'm going to talk upon the subtrigonal perforation during HOLEP. And I think basically it belongs to the capsular perforations. I think all the urological prostate surgeries has these complications of transfusions, right, capsular perforations, and especially in HOLEP, we've got a marcellata bladder incision, malfunction and bladder mucosal injury with bladder neck contracture. These are all various percentages. You can see that most of the capsular perforations belongs to 2%. But I think this slide is very important because see that complications, I'm talking about capsular perforations, it is in the early stage of your career, and it keeps on decreasing as the cases goes on. So the experience of number of cases definitely decreases the complications of all these things. Capsular perforations, we all know that there are threatened perforations, covered perforations, free perforations, which is important, a more or less obvious hole through which irrigation fluid can run into and can produce as abdominal distension. And more important is subtrigonal perforations, which is very common in HOLEP, because when you start doing HOLEP, especially for the large prostate, this is the one which you look for. And this is one complication which may dissuade from doing a HOLEPs, especially in the larger prostate. So that is the reason why I take this up complication as a particular to present here. So capsular perforations are more common while learning HOLEP, and they are very common in smaller prostates. So this is the 275-gram prostate with a very huge. I will tell you, this is the first case which I did it. This is the first case in 2011. see that even I'm not able to see the bladder itself. The prostate is so huge because I did the case not for the small prostate, but I did the case for an ideal indicated case. I mean, that should be the goal of any procedure which should be starting. We should go for a ideal indicated cases rather than choosing the easy cases. So this is the LISA, and this technique was a little different because nowadays I use from the Veru, but this is the case which started from the incision from the bladder neck. This is the bladder neck which I'm started incising and come towards the Veru. It's not very easy to edit this. I know I have done a lot of video editing of so many cases, but editing a video of the whole life is not that easy, but you need to have a correct perspective. That's the reason why this is called as a very, and see this, the incision, which is starting from bladder neck, I'm just keep on incising till we reach the capsule. It's not very clear in this video. The capsules are not very clear, but I'm incising it. And this is going in a hockey stick incision coming from bladder neck towards the apex. This is the apical area and go towards the mid zone, and you can see the bladder neck there. I'm able to read the bladder neck on the right side. From midline, from 6 o'clock position. So from there you come here and then see that when you started lifting the bladder at the level of the mid portion of the prostate gland, I'm just entering through some kind of irregular tissue. But see, almost it enters into the seminal vesicle. The prostate, when we lifted up, I didn't know what it was because it was the first case. And when you lift up the prostate, especially in the larger prostate, it's very difficult because you're going to go to the periphery of the prostate, and this is the subtrigonal perforation almost entering into the seminal vesicle. So what it is to come back again, find out the plane of the lateral area and medial area where you're dissected from the defined area to undefined areas and stay cool there. Sometimes you can perforate the bladder neck also while dealing with this subtrigonal perforation. But this one, see that you can leave that area and come out of it and go there. These complications are usually very risky to deal with because you may usually lose the control because probably this is a whole life is a one surgery where you can have a lot of complications, and the learning curve is definitely, there's a lot of people talking about learning curve. I've been starting from circumcision to robotic surgery, but this is the one surgery which gives me a scare in the early career of my life, especially for the larger prostates, more than 150 to 200. But once you master it, probably the easiest of the surgeries. So this is one lobe when we dissected this, and then I think you should, when we enter that, you come back again, you define the plane. Immediately you have to identify the plane, and this is the right lobe. I just fast forward this because the time constraint is, I know we are running late, we are already about 8:45. So this is the opposite lobe, and we did it, and for this is the complication which has happened now, and this is how the things looks. I think that is the maceration and the prostate which has been removed in this case. How does it happen? So this is, I mean, I won't be able to show that during the video. I know that the prostate is, when it becomes big, it assumes the shape of the apple, and here this is the apex and this is the base. You have to go from here, when you enucleate from this way to this way. This is the apex when you show in the cross section and the horizontal. When you start the dissection, the whole life starts from here, and you nucleate from here, it goes here. And if the prostate is very big, and this is the area where you enter into venous plane, and when you lift up the prostate and you have to reach here, this is the plane where you try to shoot off like this. So you may disconnect the bladder neck, or you may disconnect going for the triprigonal perforation, and you can enter into a lot of structures. This is how it happens usually in a larger prostate, especially more than 150, 175 gram prostates. This is a very common complication. Be aware of it. So better to get used to with a smaller prostate, which I'm going to address it. So how it is going to manage it? The covered perforation does not change the postoperative course. Only for subtrigonal perforation and deterioration, as they cause significant extravasation of the irrigation fluid and extraperitoneal space. Most of these patients can be managed by transurethral catheterization, and if there is any extensive extravasation and concern, you can put a suprapubic drainage, or sometimes you can put a perivesical drainage to clear off the externalization. How to prevent it? And I think identification of the landmarks is very important, and early exposure of the capsule with identification. You need to have a proper identification, early exposure. Try to get a plane of apex in front of the verruve, and also judicious dorsal and venous ventral incisions, so that you need to have a, usually when you start to do a hesitant cuts, especially in the HOLAB. You tend to do a hesitant cuts, so that should stop for a period of time. A judicious dorsal and venous ventral incisions are very important to prevent the complication. Continue the dissection and above below as a vapor resection. This usually laser has got a vapor resection, so you have some kind of vaporization along with the resection. And follow the curvature. Basically, when you, especially you're doing HOLAB for the larger prostate, so you assess the size of the prostate, you assess the dimension, you assess the nodularity by doing a digital rectal examination, by doing a transrectal ultrasound examination. So you know mentally the three-dimensional picture, what needs to be done, and what is the depth of the posteriorly you have to go, whether it's the median lobe or the lateral lobes. That means that is follow the curvature of the prostate, be in line with the capsule. Avoid excessive bladder resection. Sometimes you tend to go and resect the bladder neck too much. So you need to lift up the prostate once you figure out the apex and the sphincters. So avoid excessive bladder neck resections. And the correct size, when you start with the moderate size of the prostate, especially I do now today, I say that after doing about 2,000 cases, I see that 80 grams prostate is an ideal case to learn the whole membrane resection. So which gives a problem, because it develops a pseudo capsule and you get a enucleation zone at that level, more than 50 grams, you have a enucleation zone, and you'll be able to do a proper resection by visualizing the capsular. You can see that in this video that the whole thing is capsule is seen, and you can just have to lift up the prostate and maintaining the capsular identification and the anatomy. So I stop at this level.
Thank you so much, Dr. Manohar. I can imagine how terrifying it must be to see the seminal vesicle when actually you are doing an HOLAB. I would invite our own excellent presentation, but I would invite our own honorary secretary to just come forward and give the comments on the last three presentations. Professor Rajiv TP.
Good evening, everyone. It was an excellent video presentation by all the panelists in the session. First one was by Ajay Bandaka, who is especially well known in the field of bipolar enucleation of the prostate. Prostate surgery is one of the commonly performed surgeries by most of the urologists. And even though in prostate surgery, especially transurethral surgery of the prostate, bleeding was one of the most dreaded complications in the early 60s. It has been drastically come down to less than 2.53% with the advent of the improvement of the technology and vision and other things. But still, this is one of the complications which can occur even in very, very expert hands. Dr. Ajay has highlighted one case which is 85 grams and another is 135 grams. And he has shown both the types of bleeders. One is a ricocheting arterial bleeder, and another is a significant oozing, bleeding from the open venous sinuses. So in case of ricocheting arterial bleeder, one thing I have to tell to the youngsters is that one should not panic. Maintain the cool look on both sides of walls of the prostate. Identify the precise bleeder, then coagulate. You will find out the bleeder if you are very cool and you can find out. Next case is regarding the venous bleeding. And commonly, even in experts, and it occurs because of more enthusiastic, I can say, resection at the floor of the enthusiastic resection. And sometimes, especially in large prostates, when you do resection, inadvertently, the venous sinuses can be opened up. So as Ajay has highlighted, never coagulate over the open venous sinuses. You have to gentle coagulation all around the venous sinuses. This can reduce the bleeding, but it may not 100% control the bleeding. So that the rest of the bleeding can be controlled by catheterization and applying gentle traction. But if there is significant venous source, it is better to abandon the procedure, catheterize, apply traction and irrigation and come. It will automatically settle down. Regarding Rahul's presentation, he has presented two cases, one about a rectal injury, which is a very, very unusual injury during TURP. The reported incidence is 0.5 cases per lakh of TURP done. In my thing, I have seen one case. This was presented by Dr. Suresh Pattangar from Pune around 16 years back at a conference in Bombay. So immediately you will not be able to detect the leakage of urine per rectum. Once the catheter is removed and everything, the patient usually comes 7 to 10 days later saying that there is a leakage per rectum. So already Rahul has highlighted, you have to do a cystoscopy and see what is the thing, antegrade and retrograde study. And the various repairs also Rahul has definitely highlighted. That is, it can be repaired by 3 ways: transperineal repair with a pedicle Grizzly's flap. But first and foremost is that you have to do a suprapubic urinary diversion as well as a colostomy. But in one more thing I can add, if the patient is a high-risk patient, one can try a non-surgical procedure, that is endoscopic injection of fibrin glue. This has been highlighted. Next thing regarding the full-length stricture, this is even found these days. The incidence is to the tune of 2 to 3%. And the predisposing factors are very large prostate. Then another thing is that, as he has highlighted already, when you are not properly lubricating the instrument, oversized instrument when you use, and again a prolonged resection time. And again, he has already highlighted that we have a wrong notion that the temperature of the fluid. It is ideally said that room temperature is better because even than the cold irrigation fluid. Now coming into the next presentation by Manohar, it was an excellent thing about the subtrigonal perforation during a collapse surgery. And he has highlighted all the 3 points I have to say, because this is basically found when there is a large prostatic adenoma or a large median lobe. And this usually occurs at the angle at the junction of the bladder and prostate capsule. And especially when there is a large size adenoma, this angle will be more acute. So when you try to dig in that area, which may not sometimes overlook your vision, and at that point of time, you can go underneath and create this subtrigonal perforation. But he has wonderfully shown that he could even see the seminal vesicles. But these perforations can be easily be handled by the normal procedures by putting a catheter, keeping the catheter for 5 to 7 days. Or if the extravasation is significant, then you can, as he already highlighted, you can leave a perivesical drain and put in an SPC. Thank you all the panelists for a wonderful video presentation of the dreaded complications during transurethral prostatic surgery. Thank you.
Thank you very much, Rajiv sir. And we go to the last and the penultimate session of today's webinar, that is stricture and reconstruction. I must tell you that we are into the 4th hour of our webinar, but including the YouTube streaming plus the participants which are here, there are almost 150 plus participants here. That only shows the quality of presentations and the interest that has been generated. So without wasting further time, I would invite the last 3 speakers, starting with Dr. Pankaj Joshi to share his presentation. Pankaj.
Yeah, hello. Thank you, Dr. Arvind, for inviting me. Thank you, Dr. T.P. Rajiv and the Urological Society of India. Arvind, I think so. Again, can you see my share screen?
No, we cannot see your share screen.
I think I request it's the same issue I had yesterday. I'll just reboot. Maybe Dr. Shailesha can speak and I'll come back.
So do you want, we can share it from our side?
Oh yeah, if you can share it, I'll be happy.
So Abhijit will be sharing it, but we'll come after Dr. Shailesha.
Okay? Yeah, that's fine. That's fine. I'll just have one.
Shailesh sir, can we start with your presentation? Dr. Shailesha, can you unmute yourself, sir? Yes.
Yeah, I did.
You can share your presentation, sir. And
presentation is seen. I don't know.
No, no, it is not seen, sir.
I have already started my presentation.
Sir, have you opened your presentation?
I have opened.
Then you click on the icon of the share screen on the bottom.
But that is not seen.
Sir, so sir, what can we can do one thing that we have got Pankaj's presentation with us. So in the next 8 to 10 minutes, can you just get a technical support and we'll come back to you, sir.
Okay.
Okay. So Pankaj, we are starting your presentation. Pankaj? Pankaj? Pankaj?
Unmute him. Unmute him.
Yeah. Pankaj, can you unmute yourself?
Hello.
Okay,
Hello.
I've unmuted myself.
Yeah,
so thank
just a minute.
Can you see my screen?
Sir, will come after Pankaj does his presentation.
So thanks a lot, Dr. Arvind. Can you move my slide? Greetings from Pune. And I'd like to present in short about the complications of urethroplasty. So this is a complication of webinar, not being able to play your own slides. So this is intravasation, and this commonly occurs when we send a patient of stricture outside and someone injects a higher pressure, as a result of which the contrast can go in the sponge, but occasionally it also goes in the dorsal venous complex, as you can see now. And such patients can present with fever and sepsis. We believe the best person to do uretrogram is a urologist himself, and it should be done in a move the next slide, please. So this was a patient who was a 54 male who had a bulbar stricture, underwent a dorsal BM. The procedure time was less than 90 minutes. He presented in evening with a pain. Next slide, please. And this is what happened. He had severe pain. I saw him an hour later. There was an expanding hematoma. Normally we conserve. I decided to go and operate. Next slide, please. And I drained about 500 ml of blood, which came out. So what is more important is rarely we need to have a condition where we have to go and explore. Normally a pressure works very well, but if we have to go and explore, you should definitely. Hello.
Yes.
Arvind?
Yes.
Can you see my slides myself? And I think you need to unmute. Can you see the slides?
Yes.
So this was an expanding hematoma, and what's very essential is that the source of bleeding is never from the urethra. The source of bleeding is from the perineal vessels from which it bleeds. As far as aspirin and clopidogrel is concerned, we do not stop aspirin before doing a surgery. We can operate on aspirin 75. Stop, but we never do a surgery if someone is on clopidogrel. And this is the source of bleeding. It is never the urethra that bleeds. We have taken more than 6,000 buccal grafts. I have seen this happen twice. In the evening, when you go on the rounds, the patient develops a swelling in the left side of cheek, and without doubt, you know that this could be a parotid duct injury. The commonest place of injury, of course, is the exit of the duct, but it happens very commonly when you try to take a suture and close it. And that is the one reason we always say that never suture a buccal graft unless it is too small. There are two types of buccal graft. One is an oval graft and one is an long rectangular graft. If it is an oval graft, you can suture, but a rectangular graft, you should not suture. If there is a duct injury while doing the surgery, the best way is to proceed, not to coagulate and not to suture. Twice when it happened, it was self-limiting. You can actually palpate the duct over the parotid gland. You can just put in a small ethylon thread in the opening, and in one patient, we had to do a meatotomy of the opening of the parotid duct. But this is very rare. I've seen spontaneous swellings also, and one patient was from Mount Abu, and we had done surgery under spinal without graft, and he developed a swelling. And they said that occasionally a spontaneous parotid swelling post-operatively is also known otherwise. This was another patient who was 24-year male who had a pelvic fracture. You can see he has a long gap. The posterior urethra is high above the pubic bone. He had a rectal injury then, and the surgeon did a colostomy. Then he reversed the colostomy, thinking that the patient will not come back. And the patient was referred to us. When we were doing the surgery, you can see here there's a closed colostomy wound. The SPC was very lateral. This is a disastrous way. Actually, you should always have an SPC in the midline. And while doing the surgery, I could see a bubble of gas which was there on the posterior wall. So I immediately put a finger in the rectum and I could see the glove. So this is a rare complication which can happen in a patient who already had a rectal injury to start with and a lateral SPC. So occasionally rectal injury can happen. Most important thing is when it does happen, this is an acute injury, you should close it. We all urologists are very used to using Vicryl, but if you talk to the GI surgeons who work on the anal sphincter, they actually use Prolene sutures. So I close with Prolene. This was a transpubic surgery, got in an omentum in place, also did a diverting colostomy, and it saves a day when you detect the rectal injury on table than detecting it in the post-operative period. What's very essential is when we do a pelvic fracture surgery and you can't palpate the bougie in the perineum, the only way to do it is put a finger in the rectum and then try to palpate a bougie. A finger in the rectum always saves a rectal injury, and it tells us the direction of the posterior urethra. We all do flaps. It's very common in hypospadias. We do about 50 pedicle preputial flaps a year for bulbar necrosis. And occasionally on removing the dressing, you can find the blackening of the skin. This is actually only a superficial necrosis. We should not be in a hurry to debride this wound. You give it time. Over a period of time, it becomes a scab and the scab falls off. So never be in a hurry to try to debride whenever you see a blackening of the penile skin. I would like to show a photograph of doing a pedicle tube. What's very essential is the dissection has to be perfect in the layer between the dartos and the underlying buccal skin and the dartos tissue. And you should leave some vessels to the overlying skin. And by this way, you can prevent a blackening of the skin that normally we see after a pedicle flap. Many of us perform a pericatheter urethrogram. We have seen leaks happening. Whenever you see a leak, we are worried that the anastomosis is not healed. What actually happens is we tend to inject with a lot of pressure. If we see a leak, we just keep a catheter. The catheter should be kept for a period of 2 weeks more. Any catheter more than 6 weeks usually would not improvise wound healing or stop the leak that has happened. And if at all there is a leak, you just ask the patient to follow up after a period of 3 months. If it doesn't develop stricture, this becomes a fistula. In our unit, we never perform a pericatheter urethrogram unless it's a complex case. We have done a study where majority of the times the leak is only 1% if you keep a catheter for a period of 4 weeks. The most ideal way of doing a pericatheter urethrogram is you fill the bladder with the balloon with the Foley's catheter. You withdraw the Foley's and ask the patient to void. This is far less pressure than injecting by using a cannula by the side of the catheter. Occasionally, evening the patient says that I felt a pop sound, or maybe on postoperative week 1, the catheter walks out and it happens while taking a suture. Such patients should be treated delicately. This was a transpubic repair. The best way is to take him in the theater, pass a guide wire. If need be, you can take a ureteroscope and pass a guide wire over it and place the catheter. I believe the only way of reporting a complication is a Clavin endo system. And this is a Clavin endo system which we have used for the last 5 years. Type 1, where we know that no treatment is needed. This includes extravasation, fever, urethrogram, penile edema, wound infection, erectile dysfunction. Type 2, where you might need to give some medical treatment such as fever and hypotension or blood transfusion. Type 3A, where there is bleeding from the oral cavity or a Foley's fallout. Type 4, where you have to take the patient in the theater, like an hematoma or a rectal injury. And of course, none of us want type 4A and 5 complication, which are usually not related to the surgical part of it. We have published extensively, and this is one of our latest papers by me and Professor Kulkarni on the complications of urethroplasty, which has been published in the EAU. I thank Dr. Arvind, Dr. Rajiv TP, the USI and ISU for giving me this opportunity to present on complications. Thank you.
Thank you, Pankaj, for that excellent pictorial overview of complications in urethroplasty. The presentation was excellent as usual. We go to the next presentation. Shailesh sir, are we ready, sir?
Yes.
Okay, so you can share your screen.
Can you see?
No, sir, we cannot see the screen. Shailesh sir, we cannot see the screen.
No, sir. Now?
No, sir.
My screen?
Yes, now it has started. You have started sharing the screen.
Okay.
But we cannot see the slide yet.
There is no slide?
No, we cannot see the slide.
You are
okay, sir. Sir, we can see it. We can see it, sir.
Okay.
You can start, sir.
At the fag end of the long webinar, now I have reached to this level of discussing the unknown complication of surgery of Peyronie's disease. We in India comparatively do the less number of Peyronie's disease surgery. Next, third. Surgical procedure for Peyronie's disease is not recommended before stabilization of disease, and active phase is up to 2 years. 94% will experience resolution of coital pain in 18 months. Degree and complexity of the curve, how to evaluate? Baseline penile length, percentage of estimated loss of length with correction, and baseline erectile function. There are two different types of surgery. One is a plication and one is a excision or an incision and grafting. Now, our goal should be the curvature should be less than 20%. There should be minimum change in length. There should not be diminished rigidity, and the sexual sensation should remain normal. There is not a single surgical method which has emerged as the most favorable for every single patient of surgery. Now, you all know about pen recon, and this is the surgery done by Dr. Rados Genovic. And you can see that this is the patient who had a plaque in the upper part. He is a 54 years old male without hypertension and diabetes. And the most common way is just to make an incision on the plaque. So he is making incision on the plaque. The other way he could have done plication on the opposite side. But when you do plication, the size of the penis reduces. So he has a wonderfully incised the plaque. Many people still think that plaque requires excision, but plaque doesn't require excision. Now, after doing cutting of the small cut, so this is surgery is finished by Rados, and you can see the how he is doing dressing. He is very particular about the dressing and very tight ghost fish with the pad he is applying, and over that he is applying the Dynaplast. Now, not only that, he will be now taking stitches with the glans finish. Now, by and large, this dressing works very well, but in our patient, because of the weather and the ward situation, general ward situation where they have a temperature of 40 degree, and the next day after this, when we saw the patient, we opened it. The entire night, patient had a penile erection and priapism, and you can see the skin was black. And this patient started crying looking at that when we explained that you have a problem. So initially, patient had a dry gangrene. The dry gangrene usually happens because of the vascular thrombosis. Nothing was done on the glans, and still glans necrosis occurred. And then after that, because of the infection, the gangrene became wet and the surrounding tissue is also bad. So this patient was belonging to another urologist. Finally, he did amputation of the glans and excised everything, and it required a mid-penile urethrostomy. There is a supportive suprapubic cystostomy also, and after about a month, this is the situation. Now, this gentleman had come to us because he had a plaque on the right lateral wall, and there was a curvature and difficulty in the erection. His erection was though not very good, but with the help of PDE5 inhibitor, he was able to do sex. Now his penis is very small and he is not able to do intercourse. So this is the situation after the surgery. Even though, I mean, when I saw this patient, even though I do maybe 1 or 2 Peyronie's cases in a month, I was flabbergasted and I thought it is an horrendous complication, and I stopped doing surgery for 3 to 4 months. Then I started doing the literature, seeing the literature, and to my surprise, in the literature, there are several cases of the glans necrosis. Peyronie's disease and its surgery with the penile prosthesis is known to produce glans ischemic necrosis. Even if you excise plaque and do elevation of dorsovascular complex, then ischemic change doesn't occur. But when you are applying your dressing, or for some reason priapism occurs, or if there is a tourniquet syndrome, means you have put the tourniquet for a very long time, you have taken it out, but in some cases vascular thrombosis occurs. If you have applied intense external pressure, or if a patient has a Wegener's granulomatosis, I have not seen such patient, but septic emboli and venous thrombosis. So first 2 days it was a dry gangrene. After that, automatically in our ward, patient got a septic emboli and it became a septic gangrene. And lastly, the literature mentions that it is very common in diabetes mellitus and chronic renal failure. Now, after that, still today, when I do a Peyronie's surgery, I pray to God that glans necrosis doesn't occur. It's a rare, but it does occur. So you have to be careful, and this factor should be avoided. Thank you very much.
Thank you so much, sir, for that excellent presentation. I can imagine when you say horrendous complication, what you might have gone through and why you say that you did not operate for the next 3 months. I can imagine that. But excellent presentation, lot of educational value, sir. Thank you so much. We go to the last presentation of this webinar, and I invite Dr. Arvind Panda to do his presentation. He will be talking on long segment ureteric stricture reconstruction regarding that. Arvind.
Yeah, hello. Can you hear me, please?
Yes, loud and
I'm
clear.
just going to share screen.
Yes.
એક બીજું પેશન્ટ આવ્યું એ લોકો વિપિનભાઈ
Is it clear?
Yes, it is seen.
Can you see my screen? Yes.
I can see your screen.
Can you see me also? I'm not able to see myself actually.
Yes, we can see you as well. Go ahead.
Yeah. So reconstructing the long segment ureteric stricture, meniously between the cup and lip. And this was a, okay. This was a 30-year-old young male, and he was diagnosed with upper ureteric calculus of about 0.9 centimeters with mild proximal hydronephrosis elsewhere. So he underwent right ureteroscopy with laser lithotripsy and DJ stenting elsewhere, and the stent was removed after 3 weeks. And then he continued to have intermittent flank pain. He was re-evaluated in a different hospital, and he was informed that there were some residual fragments after a NCCT KUB, and he underwent rewrite ureteroscopy with a laser lithotripsy of the residual fragment, and there a narrowing was seen. So the surgeon gave a generous laser stricturotomy, laser incision of the stricture, and he put a DJ stent. And after DJ stent removal, he continued to have hydronephrosis after stent removal. So the surgeon went ahead and started changing, kept him on stent change. And this continued for about a year. And then when he came to me after a year after the second surgery, I said, let us remove the stent and see what is the situation inside. And then the stent was removed, and then we performed an IVP after 2 weeks of stent removal, because you need to give it some time for the stricture to actually delineate very clearly. And if you do it right after stent removal, we may not get an authentic picture. And what we saw is, you can see very clearly that there is a complete, almost close to complete obstruction, and there is some drainage in the delayed film, but the obstruction is quite significant. So so we decided that we have to reconstruct this ureter, and we said initially the plan was that we will do a ureterotomy. He was very keen on laparoscopic surgery, so I told, okay, I will do a laparoscopic ureterotomy. When I did a RGP, I found a stricture segment about 4 centimeters long in the upper ureter, and intra-op there was significant desmoplastic reaction, and there was extensive fibrosis. And after I excised the stricture segment, even after I mobilized the kidney well, mind you, to the right kidney, there is a limitation on how much we can actually mobilize and how much we can get the kidney to descend. And we did some ureteric mobilization on the distal ureter also, as much as feasible, keeping the vascularity. And the ureteric segment just did not come together without tension. In fact, it did not come together at all. Forget about without tension. So I converted to open surgery. I said, this is not going to work out. And then I had already planned that if it was not going to work out, I will do a ILL interposition. And there are many ways to do ILL interposition here. One is, of course, we can put a complete ILL ureter. I will come to those slides later. The other option is to do a Monty. Already it has been discussed. Using the Young Monty technique, we can use a segment of ileum. But I chose to do a ILL interposition with a tapered ileum, and I tapered over a 16 French Foley's catheter, as you can see here, and then over a 6 French stent, I anastomosed the proximal and distal margin, and I felt what I did was a reasonably good job, so I was happy about it after the surgery. And in the aftermath also, he was doing well. The drain was removed after 4 days because there was negligible drain output. The catheter was removed, and he was discharged on the day 5. And after 3 weeks, he presented with abdominal pain. And I did an ultrasound, and ultrasound showed a huge urinoma with a leak. So I immediately took him, and he was one of our hospital staff, and his wife also is a staff nurse in the OT. So immediately we took him to for a right nephrostomy, and I also put a peritoneal stent in the urinoma. And to my horror, when I put contrast through after I did a nephrostomy, there was complete obstruction of the contrast with some extravasation. Nothing was not draining at all. So this was a terrible experience. And then I thought, okay, then after 2 weeks, what happened? I removed the percutaneous sheet. It was not draining anymore. I kept that PCN for 6 weeks. And I planned that after 6 weeks, I will go in for revision, because it will be anyway difficult to go in with all that urinoma. To do a revision, it would be quite difficult. So after 6 weeks, I took him inside, and under anesthesia, I did an RGP. What I saw was that ileal segment was still viable, though it has been displaced laterally by the urinoma and fixed there. It was still viable, and the contrast was traveling up to the kidney freely. And then because then I waited, and I also did at the same time, because I had a nephrostograph, because I also had a nephrostomy. So I even put contrast nephrostomy, and I waited. After 10 minutes, we found that it was draining. It was draining, and the contrast was draining from the kidney to the bladder. At that point of time, I decided to follow the patient up, because it was draining and we didn't want to intervene so quickly. So I clamped the nephrostomy, removed the stent, and sent the patient home. After 2 days, the patient was still doing well and there was no pain. So after 2 days, I removed the nephrostomy under antibiotic cover, and I sent him for follow-up. And at 6 months after surgery, that was done in July, and this about in June, and this was in December. I asked him to do IVP, because he didn't have much hydronephrosis in ultrasound. And these are the IVPs. We can see clearly, though there is some sort of memory hydronephrosis, in delayed film, it is draining quite well with complete clearance. And we can see in delayed, and then there is no holdup of contrast anywhere, though that segment of ileum is still laterally displaced. It seems to be draining. So he remains well at 12 months. I see him almost every alternate day. There is no flank pain. There is no hydronephrosis on the ultrasound. What I want to say is that I learned some certain lessons from this particular case. One is, if there is going to be a stricture after laser injury to the ureter, there is going to be significant desmoplastic reaction and fibrosis. Ureterostomy is definitely not going to be possible. Generous so-called stricturotomy had been done with a laser. Laser is something which creates a significant area of coagulation, which sort of stretches well beyond what we can see, the visual zone. So that is why the bleeding is so less. So when we have a long segment stricture that has been caused by laser injury, we must be prepared for replacing the structured part with something, either with ileum or whatever we are, other methods also. Second important point that I have lesson I take home from this is a percutaneous nephrostomy is actually preferable in any reconstruction, any complex reconstruction involving the upper tract. A stent itself, see, I had a stent here. There was a 6-French stent in this patient. Even then, urinoma formed. So my thing is the stent is not enough, and we can do a percutaneous nephrostomy even on the day of surgery if we wish. We can initially do a primary percutaneous nephrostomy and then do this, and then turn over the patient and do the surgery. Third point is, of course, is a good take-home point, that the leak does not always mean a stenosis. I feel I got away because the stent was always there, and I removed the stent 6 weeks after the surgery. So basically, if you look at the other principles that I think we should follow is, when we try to repair a long segment stricture, always try to go intraperitoneal, because then you can wrap the omentum around it. There is one thing I had done is wrap the omentum a little bit around it. Therefore, I think I got away easily. The options we have when we have a long segment proximal stricture is one is, of course, the primary anastomosis. In patients like this, it is usually difficult. We can do renal desensus. Renal desensus is, of course, more easier in the sense it's more useful when it's a left-sided stricture. When it is a right-sided stricture, because of the renal vein that holds the kidney and the short renal vein, we are not going to really be able to do a good renal desensus beyond a point. Ureteric mobilization, yes, ureteric mobilization is something we can do, but only to a limit, because we need the ureter ends to be vascular when we do the anastomosis. The ileal ureter is something I would strongly recommend if somebody wants to do a low-risk procedure. It is the classical procedure. It has stood the test of time. The only con is it requires good function of the affected renal unit, and over time the renal unit may actually lose function because of the long segment bowel we are actually putting into the urinary tract. And again, this is ileal segment interposition. Again, is of two methods to do it. One is the Yang-Monty principle, which has already been discussed here. The reason I don't prefer the Young-Monte principle always for a single segment is I think that if we do a tapered segment, the vascularity is much more reliable, though the Young-Monte is a much more elegant procedure. I feel if there was a leak like this, I would have lost the segment if it had simply been a Young-Monte, because the entire vascularity hangs on a very small pedicle, but then it's a matter of choice. Second is, if you do a ileal segment interposition, there is low instance of graft dilatation, there is low instance of metabolic acidosis, less mucus production, and possibly less UTI. So that is what, that is my presentation. And if anyone has, I have tried to keep it as short as possible.
Yeah,
if anyone has any question or comments, I'll be very happy to take it.
Arvind, that was a great presentation. What I liked was the way you analyzed everything, how the complications happened and how to prevent it. Now we go to the last part. I would like to invite Dr. Rajendra Singh Sinnam from Imphal to give his final comments on all the three presentations. Sir, can you unmute yourself? Thank you, sir.
Thank you, Arvind. Good evening, नमस्कार, सबको नमस्कार. मणिपुर में अभी तो सोने का टाइम हो गया. मणिपुर में तो जल्दी सनसेट होता है. So anyway, I must congratulate my urology friends of the country. I am very proud of all of you, because what was urology in the early days of my career, it was quite different. I am very proud of you. There was a saying by my teachers. They said that once a stricture, always a stricture. But today, with our stalwarts like Sanjay Kulkarni, then our Professor Asopa, they have, they are international figure, and we are doing very well. The whole world is looking at us, to the urologists of our country. In 70s, there was no Siam, and where Pankaj Joshi was telling about the intravasation, we don't have. We were having still tube only. So through that, we used to do as a postgraduate student, and now we are lucky. The PGs can do under Siam, and the intravasation, if you, as he said, if you do by your own, if you adjust your pressure, you can avoid it. And one thing I would like to tell here is that any one of these patients, not that large number, incidence is very low, they may develop septicemia. So some of our colleagues wants to give one sort of amikacin or something like that. Just like when you do thrust biopsy, you give this antibiotic. So that is one. And hematoma, of course, even as the vasectomy, we have seen about 1 liter of blood collecting in the, once you find this type of hematoma, you have to open it, and there won't be any bleeding when you open it. This is what I would like to say. Regarding the extension duct, as Pankaj has said, better not to close it. I don't have much experience, because the opening of the extension is inside the mouth. Wherever it opens, if you don't suture, nothing will happen. So that is what I will tell. Regarding the other rectal injury, what he said, the rectal injury, the general surgeon should have, to me, he should have closed that coloscopy. He should have sent to us, and that could have been corrected. That colostomy closure could have been done later. That is what I would like to say. Yes, flaps, necrosis must not be frightened. That may be any just superficial one only. So that is what. Periurethral leakage, that I usually don't do the periurethral imaging. Once you stitch properly, of course, you must get trained from somebody like Sanjay Kulkarni, my friend. I called to our institute years back, and he trained my students, and I observed, and we usually don't do this periurethral, that the pericatheter imaging. We usually don't do. We just remove it, and nothing, no much complication. And regarding the insertion, then olden days we have the council type of catheter. through that, on a guide wire, we can put the catheter with the lubrication. But the council catheter, you can improvise by cutting the slightly obliquely, you cut the tip of the Foley's catheter, and in that, you are in the water channel, not in the balloon, you can backload the urethric catheter, and you can jolly well catheterize it. That anyway, Pankaj, proud of you. You have done wonderful job, and your center is known all over the world. Once again, I congratulate you. Then coming to my friend Shailesh Shah, as usual, penile fellow. I think his name must be Shivalingam also. Only Shailesh Shah, we may put him that Shivalingam. Yes, the thing is very, very rare in our state, is also very rare. And the only thing to my junior colleague, I would like to tell that this particular disease has got a active stage, the acute part, and the mature. You can understand when there is no pain, it is a mature. Then only you interfere. And that also, as far as possible, try to do minimal. Or if the pain is not much, you just assure to him and give some vitamin or something like that. Don't interfere. Application is quite good, depending on the dorsum or wherever you want to do, without injuring the neurovascular bundle. Regarding the Arvind Panda, his father is my guru. I mean, from SN Panda's son. Proud of you. When I went as examiner to CMC Belor, he was there. Now I think he has shifted from there. This urethric injury, particularly after the arrival of the urethroskop, rigid urethroskop, not this type of stricture, the avulsion of the ureter takes place. This is one of the very, what you say, nightmare for any urologist. And in such a situation, I mean, the case he has presented is a spellbound. And but once somebody comes across this, if you can put a diversion in the form of a PCN with the help of a ultrasound, well and good, give it. And of course, you have to. I mean, it is better that you better take a good consent, long consent. Of course, the patient may run away, but then if you inform that when this happens, you'll be in a better position. And so divert this system, and you may do the replacement or ileal replacement. We have done emergency replacement in Manipur, but ileum after URS avulsion, complete avulsion from PUJ right up to the UBJ, it functioned very well. On this particular case, I want to ask Arvind. Arvind, being on the right side of the the appendix, how was the length of the appendix? If the appendix was a very lengthy one in some individuals, the appendix is found to be very lengthy. Can you think of using appendix, which like in Metrophonop we are using? So my contention is that if the length of the appendix is quite good, I think you may try that also. Anyway, once again, I thank three of you. You have done very well. I thank I would like to thank the USI, Arvind Ganpule, your center, Mujahid Patel Urological Center. From all over the globe, people are coming. It is a mecca of the urology. I've been there. I have given a lecture. Hats off to you all. Thank you very much. Good night from Manipur.
Thank you very much for your. Thank you so much for your seamless style and that signature style of explaining things and summing up everything. Thank you so much, sir. Before I hand over the mic to Raju sir for the concluding comments, I would like to take this opportunity to thank each and every presenter for presenting in such a nice way, for being courageous in bringing out their own complications, analyzing them, and presenting them. It really requires courage to do so. Thank you so much for your efforts. Raju sir, over to you.
Thank you, Arvind, for wonderfully moderating such a marathon session. This has extended to 4 hours. But all the presenters have presented a beautiful case presentation of the complications of various procedures which has happened during their practice. And it has been wonderfully depicted, and it has been discussed how to prevent it, what was the cause for this. This was the basic idea of this thing, because everyone faces complications during their practice, and how it has occurred, what was the cause for it, how it has been appropriately managed, and the outcome of it. This was what we wanted to highlight during this webinar. It has been wonderfully done. And my thanks on behalf of the Council of USI to all the faculties in this webinar, and Arvind especially for wonderfully moderating the session. My thanks to all the viewers who are patiently sitting with us. Even at this moment also, combined Facebook, we have more than 100+ viewers. And this is a remarkable thing. We are approaching 9:45 now. And I also would like to thank the Central Office of the USI, Mr. Navneet Arora and Kiran Arora for the extensive logistic support they have provided. And thanks to Indus, Aileron Division of Indus Pharma for the educational grant support which they are rendering to USI for these programs. Thank you all once again. Good night. We'll meet on Sunday.